Dear colleagues, welcome to the second annual OncoAlert Colloquium brought to you by the OncoAlert Network and our amazing partners at ESO, the European School of Oncology, eCancer, EONS, the European Oncology Nursing Society, MASC, the Association of Supportive Care, SWOG, the Society for Geriatric Oncology, IGCS, the International Gynecologic Cancer Society, and SWOG Cancer Research Network. My name is Gilbert Morgan. I'm a clinical oncologist, displaced Texan practicing in southern Sweden, and director of the OncoAlert Network. The colloquium, which you're about to see, is an end-of-the-year review taking place daily from January 10 to January 16, bringing you the most impacting findings in oncology of 2021, divided by tumor type, and delivered by an amazing hand-picked faculty of world-renowned oncologists, oncology nurses, and of course, amazing patient advocates. This, as with every OncoAlert initiative, has been realized with absolutely no financial support. All the presentations which you are about to see this week will be free, always available, and will require no registration, and we will not be tracking your data. The amazing faculty that makes up our network believes that through working together and making education available to all is the only way to move forward for the development of our field and for the better treatment of our patients. We welcome you to day 5 of the colloquium, where we'll be seeing special sessions. Our presenters are Dr. John Haanen, Research Group Leader in the Division of Molecular Oncology and Immunology at the Netherlands Cancer Institute in Amsterdam, presenting on immunotherapies. Dr. Vivek Subbiah, Center Clinical Medical Director of the Clinical Center for Targeted Therapies at MD Anderson USA, presenting on targeted therapies. Dr. Christian Rolfo, President of the International Society of Liquid Biopsies, Mount Sinai USA, presenting on liquid biopsies. We then move on to the SWOG sessions, where we have Dr. Jessica Hwang of MD Anderson Cancer Center presenting on the SWOG 1614, Dr. Nagla Karim, Medical Director of the Georgia Cancer Center's Clinical Trials Program in the US, presenting on SWOG 1929. Moving on to our OncoAlliance sessions, Dr. Fumiko Chino, Radiation Oncologist at Memorial Sloan Kettering, presenting on financial toxicity, Dr. Nicole Kuderer, presenting on COVID-19, and ending with Dr. Narjust Duma, Associate Director of Cancer Center Equity Program at Dana Farber USA, presenting on disparities. On behalf of OncoAlert, our partners, and our faculty, it is an immense honor to be able to present this colloquium for you, our colleague. So without further ado, day 5 of the OncoAlert Colloquium. And to get us started, Dr. John Haanen.
First of all, Jill, thank you very much for the kind invitation to present again on this OncoAlert Colloquium, now for 2021. My name is John Haanen. I'm a medical oncologist working at the Netherlands Cancer Institute in Amsterdam. And my highlights are immunotherapy of the 2021. Here are my disclosures. So first of all, I would like to wish all listeners to this presentation a very happy and healthy 2022. The agenda for today is starting off with what I think are the most exciting new data in cancer immunotherapy of 2021. And it will focus on 3 studies, the Keynote 7 and 16, the Empower 010, and the Checkmate A16. And I will end with some conclusive remarks. So in my opinion, the hottest in cancer immunotherapy of 2021 perhaps were not even the trials that I will present, but was the fact that in 2021, the vast majority of cancer patients, at least in the Western world, that are at high risk for severe COVID-19 or even dying from that were vaccinated. At least one time, but the majority 2 or 3 times, and some may even have already received a booster vaccine. Now, going into what was really the aim of my presentation is what I think are the most important achievements in cancer immunotherapy of 2021. Now, already I've seen a couple of years that immunotherapy, with especially checkpoint inhibition, is moving to earlier stages. Adjuvant immunotherapy has been approved, for stage 3 melanoma, for high-risk clear cell cancer, renal cell cancer, and also for esophageal cancer following chemoradiation and surgery. Now in 2021, there were 3 important randomized controlled studies presented at ASCO, ESMO, ACR, SMR, so at several symposia and congresses. And I think these 3 trials are also practice changing and therefore are the highlights for me of 2021 immunotherapy. Let me start off with the randomized controlled trial with adjuvant pembrolizumab in stage 2B to see melanoma, the Keynote 716 study. So when we look at the melanoma-specific survival for stage 2 and stage 3 disease, and as already mentioned, for stage 3 disease, adjuvant nivolumab or pembrolizumab has already been approved. You can see that especially for patients with T3B, T4A, and T4B primary tumors, that these tumors have, patients with these tumors have a worse outcome than, for instance, patients with stage 3A disease. So therefore, the idea that these patients may also benefit from an adjuvant therapy was an interesting question, and this question was addressed in the Keynote 716. So in the study, almost 1,000 patients were randomized between 1 year of pembrolizumab, 200 milligrams intravenously every 3 weeks, versus a placebo. The key eligibility criteria were patients needed to have an age of 12 or older, newly diagnosed and resected high-risk stage 2 melanoma, and a good ECOG performance status. Patient was stratified for T-stage and also for pediatric status. Following this treatment and upon recurrence, unblinding of the study will be performed, and then patients may cross over that received placebo to pembrolizumab, or patients could be re-challenged with pembrolizumab for up to 2 years or until progression. Primary endpoint of the study was relapse-free survival per investigator assessment. And here are the baseline characteristics. Now, see that there was only 1 child below 18 years in both arms. The majority of patients, therefore, were adults. 61% was male, and 63% had stage 2B disease, and 35% had stage 2C disease. And here you see the updated recurrence-free survival presented by Jason Luke at the SMR symposium, where you can see that there was a clear difference in relapse-free survival in favor of the pembrolizumab-treated patients with a hazard ratio of 0.61 and a relapse-free survival rate at 18 months of almost 86% for the pembrolizumab-treated patients versus 77% for the placebo-treated patients. When we look at the key subgroups analysis here in this forest plot, you can see that almost all subgroups seem to benefit. A little bit strange is that the T4B group, so the patients with the thickest and ulcerating melanoma, seem not to benefit as much, but this could still be the result of an immature trial, and therefore we have to wait longer in order to be sure. There were, of course, more patients having a recurrence in the placebo arm with 16.8% versus 11.1% in the pembrolizumab-treated arm, and there appeared fewer distant recurrences in the pembrolizumab-treated patients versus the placebo, 7.8%. Adverse events were seen in both arms, but treatment-related adverse events were almost 80% in the pembrolizumab-treated group versus 61% in the placebo arm, and 16% of patients had a grade 3 to 4 adverse events. 15% of the patients receiving pembrolizumab had to discontinue the treatment because of side effects. There were no deaths. When we look at the adverse events of interest, so the immune-related adverse events, hypothyroidism and hyperthyroidism were most commonly seen, all of course in the pembrolizumab treated patients population, although there were some also in the placebo arm. Colitis, hepatitis, hyperphagitis, adrenal insufficiency, myositis, severe skin reactions, pneumonitis, all, and even type 1 diabetes were seen in the pembrolizumab treated patient population. 20% almost received hormonal therapy for management of their hormonal dysfunction. In most cases, thyroid hormones was given, but sometimes also hydrocortisone or insulin. There was no statistically significant difference in health-related quality of life between the two arms over time. So, in summary, adjuvant pembrolizumab is associated with a significant reduction in the risk of disease, recurrence, or death compared to placebo for patients with resected high-risk stage 2 melanoma with a hazard ratio of 0.61. 20% of patients in the pembrolizumab arm received hormonal substitution for the management of endocrinopathies. Usually these are lifelong, something really to be aware of. And health-related quality of life was similar between the two arms, and therefore Jason Luke stated that adjuvant pembrolizumab is an effective treatment option in patients with high-risk stage 2 melanoma. Now, also in non-small cell lung cancer, a first randomized controlled phase 3 trial was presented, the EMPOWER-010 study. So in this study, patients with completely resected stage 1B to 3A non-small cell lung cancer were randomized after they had received resection, followed by adjuvant platinum-based chemotherapy with either atezolizumab for 1 year or best supportive care. In total, 1,005 patients were randomized between these two groups. The primary endpoint of the study was investigator-assessed disease-free survival. This was tested hierarchically with the PD-L1 positive in tumor cells, 1% or higher population in stage 2 to 3A first, and if that was positive, or randomized stage 2A to 3A population, if that was positive, in the intention to treat, so all randomized patients, including also the stage 1B patients. The baseline characteristics, 65% of patients had non-squamous histology. The majority, of course, had stage 2A to 3A disease. Only 12% had stage 1B disease, and about 50% of the patients had PD-1 expression in tumor cells of 1% or higher. And here you see the primary endpoint, the disease-free survival in the PD-1 positive population, or randomized stage 2 to 3A, and the total intention to treat population. And as you can see, in the PD-1 positive population, there's a statistically significant difference in favor of the atezolizumab treated patients with a hazard ratio of 0.66. And there was also a statistically significant difference in all randomized stage 2 to 3A population, now with a hazard ratio of 0.79. The intention to treat population, that difference was not statistically significant. When we look at disease-free survival by PD-L1 status, you can see that whether you include the EGFR ALK mutated or not, especially the PD-1 positive subgroup benefits mostly from the treatment. The higher the PD-1 expression in tumor cells, the better the outcome for this patient. Incidence of disease relapse was much lower in the PD-1 positive in all randomized and intention to treat for the atezolizumab treated patient versus best supportive care. So that was across all the different populations. So at the interim analysis that was presented by Enriqueta Philippe at ESMO 2021, the interim analysis showed a similar pattern of relapse between the two study arms. The time to relapse was in favor of the atezolizumab treated patient in the PD-1 positive population, with minimal differences seen in the all randomized stage 2 to 3A and ITT population. There was a higher rate of post-relapse chemotherapy use in the best supportive care arm. I don't think that is surprising. And longer term of follow-up is, of course, warranted to, and that may reveal differences in relapse patterns and treatment options. So to summarize, this is the first phase 3 study of cancer immunotherapy to demonstrate disease-free survival improvement in the adjuvant non-small cell lung cancer setting after platinum-based chemotherapy, and therefore these results are really exciting. Adjuvant atezolizumab following complete resection and adjuvant chemotherapy showed statistically significant disease-free survival benefit in the PD-L1 positive population and also in the all randomized stage 2 to 3A population. But clearly there was the best benefit was seen in patients with PD-L1 expression, and especially high PD-L1 expression. The safety profile of atezolizumab was consistent with prior experience with this treatment. And atezolizumab may therefore be considered a practice-changing adjuvant treatment option for patients with PD-L1 positive stage 2 to 3A non-small cell lung cancer, was stated by Enriqueta Philippe at the end of her presentation. So the last study I want to mention and discuss is the neoadjuvant chemoimmunotherapy in resectable non-small cell lung cancer patients. So this is different from the two prior studies because the chemoimmunotherapy is now given prior to surgery. So these are newly diagnosed resectable stage 1B to 3A non-small cell lung cancer patients with good performance status without any EGFR or ALK alterations. They were stratified by stage and PD-L1 expression, and a total 358 patients were randomized 1-to-1 between the combination of nivolumab plus chemotherapy versus chemotherapy alone. There was radiologically restaging a surgery within 6 weeks post-treatment, and optional was adjuvant chemotherapy or radiotherapy. The primary endpoint was pathological complete response by independent review and event-free survival, major pathological response by independent review, and overall survival by secondary endpoints, and objective response rate by independent review, and predictive biomarkers, including circulating tumor DNA, were also exploratory endpoints. So when we look at the baseline characteristics, it's clear that the majority of patients had stage 3A disease, 50% had non-squamous disease, and the majority were current or former smokers. 50% had PD-1 expression, at least to some extent, and about 1/5 to 1/4 had a high tumor mutation burden of 12.3 mutations per megabase or more. So when we look at the treatment and surgery summary, you can see that 89% of the patients in both arms received the neoadjuvant treatment. 94% finished the 3 courses, and 83% received definitive surgery, mostly lobectomy. Some of them also received pneumonectomy or others. R0 resection were seen in 83% of patients receiving nivo plus chemotherapy versus 78% in the chemotherapy arm. Patients with delayed surgery were more or less similar between the arms, and patients with canceled definitive surgery, we saw that there were some more disease progression in the chemotherapy alone arm. When we look at the primary endpoint, so the pathological complete response with neoadjuvant nivo plus chemo versus chemotherapy, there's a clear difference in favor of the nivo plus chemotherapy arm, with 24% of the patients having a pathological complete response compared to 2.2% in the chemotherapy arm. And of course, this difference is highly statistically significant with an odds ratio of almost 14. For patients that really received a resection, the difference was even better, so 30.5% versus 3.2%, and the primary tumor only in the intention to treat 25.7% versus 2.8%. This was true for all subgroups, so whether they had a stage 1B or T, a 2 disease or 3A disease, squamous cell, non-squamous cell, but also PD-L1 expression or no PD-L1 expression. So importantly, for all subgroups, the combination of nivolumab plus chemotherapy led to a higher pathological response rate. When we look at the secondary endpoint, the major pathological response with neoadjuvant nivo plus chemo versus chemo, again, you can see that there's a clear difference. So major pathological response means that 10% or less vital tumor cells are present in the resection material. We now see almost 37% major pathological response versus almost 9% in the chemotherapy arm. Here, the odds ratio was 5.7. Again, this difference was important and statistically significant. For patients with resection, that was even better, 46.8% versus 12.7%. And for the primary tumor only in the intention to treat, 40.2 versus 12.3%. And here you see the depth of the pathologic regression in the primary tumors. You can see the majority of these of patients here in this rectangular having a pathological complete remission, and here are the patients with a major pathological response, not having a pathological complete response. And you can see that there's quite a huge difference here. The median viable tumor cells were 10% in the nivo plus chemo arm versus 74% in the chemotherapy arm. Was there objective response rate and radiographic downstaging? So these were, let's say, exploratory analysis. And again, what we have seen before in many other tumor types is that the radiological assessment really underestimates the depth of the response that pathologists are seeing. So now we see a complete response rate of only 1% in nivo plus chemotherapy arm, which was even higher in the chemotherapy alone arm, and a 53% partial response and a 39% stable disease. When we look at the radiographic downstaging, that was 31% versus 24% between the two arms. So clearly a huge difference with what the pathologist sees. Treatment-related adverse events are something that we already know from this treatment. So most of these were probably chemotherapy induced. But of course, we do see some immune-related adverse events only in the nivo plus chemotherapy arm, with rashes, thyroid dysfunction, type 1 diabetes, hypophysitis, adrenal insufficiency, pneumonitis, and hypersensitivity reactions. So typical what is seen for patients treated with anti-PD-1. So to summarize, Checkmate A16 showed a statistically significant improvement in the primary endpoint of pathological complete response with an odd ratio of almost 14, and benefit consistent across disease stages, histologies, TMB, and PD-L1 expression levels. The addition of neoadjuvant nivolumab to chemotherapy maintained a tolerable safety profile and did not impede the feasibility of surgery, which is always an issue with neoadjuvant treatment. Checkmate A16 is the first phase 3 study to show the benefit of neoadjuvant immunotherapy plus chemotherapy combination for resectable non-small cell lung cancer, and nivolumab in combination with chemotherapy could represent a potential new neoadjuvant option for these patients. And this was presented by Patrick Forder at ACR for the first time in 2021. So what are my conclusions? When we look at adjuvant, there are potentially 2 new indications for adjuvant immunotherapy that have emerged in 2021. 1 year of pembrolizumab in high-risk stage 2 melanoma, 1 year of atezolizumab in resected stage 2 to 3A non-small cell lung cancer, especially PD-1 positive, following adjuvant chemotherapy. What are the cautions here? Data are still early, with no data on overall survival yet, and what to do upon progression. That is something that remains a question in, I think, almost all adjuvant immunotherapy studies. Then when we look at the neoadjuvant, until now, neoadjuvant immunotherapy is not a standard of care, despite impressive results coming from small studies in diverse cancer types. Almost all of these studies show a very positive signal with immunotherapy alone, or sometimes combined with chemotherapy. Neoadjuvant chemoimmunotherapy in non-small cell lung cancer shows a strong signal of activity with a very high pathological response and major pathological response rates, together with safety. Again, there are no data on event-free survival yet, and I think we really have to wait until we see these event-free survival data. And of course, it's expected that these event-free survival data will be in favor of the Nivo plus chemotherapy treated patients. But of course, that will be required, I think, in order to really make this a practice-changing treatment. And with that, I really would like to thank you all for listening. And again, OncoAlert for allowing me to speak.
Good morning, good afternoon, good evening, everyone. Thank you for listening. What a year it's been. At the outset, I'd like to thank the OncoAlert, Colloquium, and especially Gil Morgan for this opportunity for me to talk on updates in targeted therapies 2021. As we know it, the whole world is engulfed and overburdened with COVID in this era. How do we restore the balance of cancer care and cancer clinical trials in the COVID era, especially with the spiking Omicron cases? Nevertheless, research in cancer moves on as we had the recent update and publication of Hallmarks of Cancer, New Dimension by Dr. Doug Hanrahan that enhances and adds new dimensions to the hallmarks of cancer that include unlocking phenotypic plasticity, non-mutational epigenetic reprogramming, senescent cells, and polymorphic microbiomes. So the next decade is going to be interesting because all investigators are going to be working on impacting and targeting these new emerging hallmarks and new dimensions. So let's take a step back. So how did we treat advanced and metastatic cancers and even rare cancers before the era of molecularly targeted therapy? It was a one-size-fits-all approach. For any cancer, it was a trial and error method by administering one-size-fits-all chemotherapy. Today's reality is that metastatic epithelial malignancies remain incurable. Statistical victories with p-value less than 0.05 are hailed as major breakthroughs and advances despite survival gains of weeks to months. So what is personalized medicine? From the current practice of one treatment for the average patient, personalized medicine, which is yet to be realized, customizes the right treatment for the right patient at the right time, at the right clinic with the right biology. We have immunotherapy. The immune system recognizes a mutanome. There are genomic defects that clearly pair with immunotherapy. And there's been a marriage of genomics and immunotherapy with mismatched repair gene defects in colorectal cancer and other cancers. In fact, recently, the high tumor mutation burden was also identified as a biomarker and in fact, FDA approved for immune checkpoint therapy. In addition, we see molecular anomalies like PD-L1 amplification in Hodgkin's lymphoma and multiple other cancers that make the tumors susceptible to immunotherapy. So we have a lot of new targets, immunotherapy, beyond PD-1, CTLA-4, and recently the LAG-3, BTLA-4, OX40, CD27, CD137, and we have a host of kinase inhibitors, all the monoclonal antibodies, the mAbs, the small molecule inhibitors, the NIBs, the selpercatinib, pazopanib, pralsetinib, dasatinib, tipifarnib, osimertinib. Our work in the targeted therapy space is to bring new drugs to patients with cancer, navigating the roadway of funding, space, staff, training, collaborating between industry, academia, NCI, using patient advocacy, overcoming regulatory issues and ethical issues in the context of complex insurance infrastructure, providing multidisciplinary, compassionate care to improve the quality of life of our patients with cancer. So we have a host of targeted therapies. So the next set of slides, I'll be focusing upon two targets and my experience with targeting BRAF and RET among all the precision oncology targets. So why BRAF? I'll be talking about initially the precision oncology paradigm, talking about the basket trials in oncology, discussing about one of the first basket studies in oncology, the vemurafenib basket study, also the rare oncology agnostic research, the ROAR study, and then delve upon the RET inhibitors in oncology. So these are novel precision medicine trials. Umbrella study is one type of cancer with different genetic mutations, whereas basket studies are histology independent studies where multiple types of cancer with the common genetic alteration receive the same drug. So as you can see, a patient's tumor is sequenced, and depending upon the mutation, the patients are enrolled or assigned to different baskets of studies. So let's talk about BRAF in cancer. Why BRAF? BRAF mutated oncogene is seen in 5 to 10% of human malignancies, and most of the tumors express BRAF are rare or ultra rare cancers. It results in constitutive activation of the MAP kinase pathway, and the most common mutation is a BRAF V600E. It's a driver mutation in multiple solid tumors such as melanoma, colorectal cancer, papillary thyroid cancer, non-small cell lung cancer, ovarian cancer, and GIST. Also, it is a driver alteration in multiple hematological malignancies that include Langerhans cell histiocytosis, Erdheim-Chester disease, hairy cell leukemia, etc. So in one of the first iterations of the basket study, this was a WEM basket study, and this used the histology independent approach wherein a patient with any tumor type, be it non-small cell lung cancer, anaplastic thyroid cancer, breast cancer, ovarian cancer, multiple myeloma, colorectal, would be enrolled in the vemurafenib monotherapy basket study based on the presence of BRAF V600 alteration. The non-small cell lung cancer response rate was 42%. And the Erdheim-Chester disease, which is an extremely rare disease, or Langerhans cell histiocytosis, the response rate was 43%. And based on one of these arms, the expansion cohort of one of these arms, vemurafenib as a single agent got even FDA approval for this disease. Beyond non-small cell lung cancer and Erdheim-Chester disease, responses were seen across multiple rare tumors like anaplastic thyroid cancer, pleomorphic xanthoastrocytoma, cholangiocarcinoma, and among patients with colorectal cancer who received vemurafenib and cetuximab. At the same time when this study was ongoing, there was a Nature paper that showed that colorectal cancer has an innate mechanism of resistance with EGFR if they harbor the BRAF V600E alteration. So there was no activity with monotherapy BRAF inhibition, but patients with colorectal cancer who received vemurafenib and cetuximab in combination showed responses. So this validated BRAF V600 as a therapeutic target beyond melanoma, which leads to tumor agnostic sensitivity to vemurafenib with the exception of colorectal cancer, and in colorectal cancer with the addition of an EGFR pathway inhibitor. Again, as you can see, responses were seen in multiple tumor types. And recently, the pan-cancer efficacy of vemurafenib in BRAF mutant cancers across the multiple cancers was published. And you can see the deep activity of vemurafenib in multiple tumor types. Science moved on. Then BRAF and MEK inhibition was approved and standard of care in melanoma, which is the poster child for BRAF inhibition. So what the combination of BRAF and MEK did, so it was led to sustained target inhibition to observe more prolonged and anti-tumor effect. It also delayed and potentially prevented the development of resistance in addition to delaying hyperproliferative lesions and secondary malignancies. Then we designed the ROAR basket study. What's a ROAR basket study? It's a rare oncology agnostic research wherein the idea was similar. And patients with multiple rare tumors were enrolled on the dabrafenib and trametinib study as long as these tumors harbored the BRAF V600E alteration. The primary endpoint was investigator-assessed objective response rate. The initial responses were phenomenal in this extremely lethal cancer called anaplastic thyroid cancer. And we could see that these patients who did not have any targeted therapy before benefit from this therapy. And based on this data, the FDA approved the first targeted therapy for the treatment of anaplastic thyroid cancer. And this was the first FDA-approved treatment for patients with aggressive form of thyroid cancer, and the third cancer with this specific gene mutation that this drug combination was approved for. So again, we had successes in precision oncology basket studies in extremely rare subsets of tumors. Building upon that, recently, the dabrafenib and trametinib combination in the ROAR basket study read out for the cholangiocarcinoma cohort. And the investigator-assessed objective response rate was 51%, and it was included in the NCCN guidelines. So what is the implication? So BRAF seems like a tissue-agnostic target beyond melanoma, and the clinical benefit of dabrafenib and trametinib supports this combination therapy as a treatment option for BRAF V600 mutated biliary tract cancer. And we recommend routine testing for BRAF V600E alterations for all patients with biliary tract cancer. Let's move on to RET. So talking about RET aberrations in oncology, the recent 2 FDA approvals for selective RET inhibitors, pralsetinib and selpercatinib. RET is a receptor tyrosine kinase required for normal development. Alterations in the RET structure and function can lead to tumorigenesis. RET can be activated by 2 major mechanisms, the oncogenic RET mutation and dimeric RET fusion. Oncogenic RET alterations have been identified in numerous cancers, and it was one of the first oncogenic kinase fusions cloned from an epithelial tumor in 1985. In 2017, we saw 2 selective RET inhibitors enter first-in-human clinical trials, and 2020, this was FDA approved. So RET, as I said earlier, is activated by 2 major mechanisms in cancer, RET fusions and RET mutations. RET fusions are seen in 2% of non-small cell lung cancer, 10 to 20% of papillary and other thyroid cancers, and less than 1% across multiple cancers that include GI cancers like pancreatic cancer and colorectal cancer. RET mutations are seen in over 60% of sporadic medullary thyroid cancer and almost universally in hereditary form of thyroid cancer, the MEN2A syndromes. A number of oncogenic RET activating point mutations have been identified to date. And the most common RET fusion in non-small cell lung cancer patients is the KIF5B, and the most common activating RET point mutation is the RET M918T. So why did we need selective targeted therapies for RET altered cancers? We used multi-kinase inhibitors like cabozantinib, vandatinib, lenvatinib, sorafenib, dovatinib, motacinib, all have non-specific off-target activity against SRC, VEGFR2, and other kinases, so which prevented a selective inhibition of RET targeting that led to extreme discontinuation rates and dose reduction rates. So we needed superheroes for selective RET inhibition. So how do we define superheroes? When we take lung cancer, which is now the poster child for precision oncology, if you take drugs like osimertinib, ceritinib, or crizotinib, or alectinib, the PFS is 18 months. When we compare these non-specific multi-kinase inhibitors, the PFS is 6 months. So we needed definitely superheroes for RET inhibition. Enter selpercatinib, enter pralsetinib. So we're going to be talking about both these selective RET inhibitors. First, selpercatinib. Selpercatinib or LOXO-292 is a potent and selective RET inhibitor. After demonstrating high kinome selectivity and demonstrating its efficacy in xenograft models, it also showed blood-brain barrier penetration in an orthotropic brain model. The Libretto 001 study is a phase 1 dose escalation design, and patients, as long as they harbored a RET alteration, were enrolled on this study. The recommended phase 2 dose was 160 milligram twice daily. And recently, this was published in the New England Journal of Medicine and received FDA approval based on the expansion cohort of the phase 1/2 study. Right? What was the efficacy of the selpercatinib? In the primary analysis set of 105 patients, the objective response rate was 68% in prior treated patients. And selpercatinib was active regardless of prior chemotherapy, regardless of receipt of prior immunotherapy, regardless of prior multikinase therapy. The CNS objective response rate was 91%. In the treatment naive cohort, the response rate was 85%. And based on this data of the efficacy of selpercatinib in RET fusion non-small cell lung cancer, selpercatinib received FDA approval for previously platinum-based treated patients and previously untreated patients. Selpercatinib is now US FDA approved for the treatment of RET fusion positive non-small cell lung cancer, for the treatment of adult and pediatric patients with RET mutant medullary thyroid cancer, for the treatment of pediatric and adult patients with advanced RET fusion positive thyroid cancer who require systemic therapy. And you got to note that these are line agnostic approvals. The next drug is the Blue 667 or pralsetinib, which is a highly potent selective RET inhibitor and more potent and selective against the multikinase inhibitors. Pralsetinib potently inhibits the RET alterations and RET mutants while sparing the VEGFR2, as you can see in this chart. The ARROW trial was a first-in-human trial designed with pralsetinib, and the MTD of 400 milligram once a day was selected based on the early phase clinical study. After showing dose-dependent inhibition of the RET pathway that include MEK, ERK, dual phosphatase 6, and SPRODY4 mRNAs, it also showed dose-dependent decline of MTC tumor markers, the CA and calcitonin. So as you can see here, early in the course, pralsetinib demonstrated activity against highly invasive RET mutant MTC. And again, similar activity was seen in heavily pretreated RET fusion positive non-small cell lung cancer as well. So based on this, the ARROW study was expanded to a phase 2 dose expansion. The primary endpoints was objective response rate, and the secondary endpoint was duration of response, CBR, and disease control rate. So similarly, in the RET fusion positive non-small cell lung cancer per central radiology read showed a 73% objective response rate in the treatment naive cohort and 61% objective response rate in the post-platinum data set, and was FDA approved. And for all RET mutant medullary thyroid cancer patients, the objective response rate was 74% in the treatment naive cohort and 60% objective response rate in those previously treated. Pralsetinib received FDA approval in 2020 for treatment of RET positive non-small cell lung cancer and RET positive thyroid cancers. Again, this was a line agnostic approval for RET fusion positive non-small cell lung cancer, RET mutant medullary thyroid cancer, RET fusion positive thyroid cancer who requires systemic therapy. The RET inhibitor superheroes have arrived. As you can see, the discovery, preclinical, and rapid clinical validation with registrational studies leading to FDA approval straight from phase 1 studies attest to the response and to the activity and potency of these drugs. Responses were observed regardless of treatment history, RET fusion partner, RET mutation, CNS involvement, or gatekeeper V804M coverage. You see the timeline for this FDA approval. Again, RET fusions were identified as oncogenic drivers in non-small cell lung cancer in 2012. And in 2017, 2 drugs entered first in human trials. And 2020, we have selective RET inhibitors FDA approved 3 years from a first in human clinical study. Cancer, as we see in the hallmarks, always mutates. It recapitulates Charles Darwin's evolution. So what do we see with selective RET inhibitors? Resistant to selpercatinib and pralsetinib are mediated by these solvent front alterations on the kinase domain, the G810C and G810S. The identified selective RET inhibitors, selpercatinib RET mutants, are cross-resistant to pralsetinib. because they use an unprecedented binding mode to dock into the RET kinase. So we definitely need second generation RET inhibitors that cover the gatekeeper in addition to solvent front alterations to cover these new mutations. That is on-target resistance. What about off-target resistance? Again, we saw a patient with acquired NTRK fusion on sulfatinib therapy. And there have been reports of MET amplification, MET fusions being reported post-RET inhibition. Taking a step back, now talking about tissue agnostic approvals. The sun rises in the new era of tissue agnostic approvals, which is driven again by genomics and FDA approvals. The FDA approved in 2017 pembrolizumab for solid tumors based on MSI high. Importantly, this was a tissue agnostic approval. The approval was based on a genomic marker, and the approval was based on retrospective and real-world data. Larotrectinib was subsequently approved for all adult and pediatric NTRK fusion positive patients in 2018. Entrectinib received also US FDA approval for NTRK fusion in 2019. Pembrolizumab was also approved for a tumor mutation burden greater than equal to 10 mutation per base pair in adult and pediatric solid tumors in 2020. And even more, belzutifan, hypoxia-inducible factor for adults with VHL disease, also was approved in 2021. This drug called dostarlimab for adult DD MMR solid tumors was also approved in 2021. In 2020, 2021, the death rate from cancer in the US declined by 29% from 1991 to 2017. The decline in death from lung cancer drove the record drop. Deaths fell from 3% per year from 2008 to 13. And these were from advances in screening, in early detection, and also immunotherapy and advances in targeted therapy in non-small cell lung cancer. Unfortunately, to put a wrench for the whole advances, COVID has overburdened us. We shall prevail. I think science has given us therapeutics, vaccines to overcome this COVID era. We look beyond the pandemic to push the cancer needle ahead. One of the major silver linings of the COVID pandemic is the way we conduct clinical trials. Clinical trials are being designed from being clinical trial-centric to more patient-centric with remote health, telehealth visits, and so on and so forth. So hopefully in the future, we are going to be seeing some of these incorporated in clinical trial designs. So we have a whole new dimension cut out for the next decade for us to go after in precision oncology. Unlocking phenotypic plasticity, non-mutational epigenetic reprogramming, polymorphic microbiomes. We have hundreds and thousands of organisms, mainly bacteria, in us, in the lung, in the colon, in our respiratory cavity, that can impact the vulnerability of immunotherapy and other agents. We are still scratching the surface of polymorphic microbiomes. And many scientists are fervently, feverishly working on this enough senescent cells. So the next generation, I think we have a chart, path forward. And the recent publication of Hallmarks of Cancer, the New Dimensions, will give us a motivation to work on more so that we can end cancer. Again, I thank, the OncoAlert Colloquium, specifically Gil Morgan, for the wonderful opportunity. And please stay safe all. I thank all the motivated patients, their caregivers, all the global collaborators, investigators for helping enrolling on all these practice-changing clinical trials. Thank you so much.
Hi, my name is Rolfo. I'm Associate Director for Clinical Research at the Center of Thoracic Oncology. I'm professor of medicine at Icahn School of Medicine, Mount Sinai, New York. It's a pleasure to be here today in the OncoAlert Colloquium, and we will discuss about the liquid biopsy in these 20 minutes. That's are my disclosures. I would like to thank to the organizers, especially to our friend Gilberto Morgan, for the opportunity to discuss this important topic. So living in New York, you have the opportunity to see sometimes actors. I have twice the chance to see Woody Allen on the street, and I was thinking about this to make this kind of funny advertisement. Everything you always want to know about liquid biopsy, but we're ever afraid to ask. We'll discuss some of the things focused specifically in lung cancer, that is my area of expertise. So the change of the paradigm happened some years ago when we start to include molecular oncology in the decision-making, and we include also some new predictive biomarkers, intermediate endpoint biomarkers, and also other molecular biomarkers that make easy to tailor these treatments in several patients. Some of the tools for that, in the beginning, we have only tissue biopsy with some advantage and disadvantage. The advantage obviously is the pathological information that we can get from there, but also the disadvantage could be the lack of heterogeneity capture, and also the impossibility to do repeating this molecular profiling investigation due to the invasive method, but also the limited tissue quantity that we can have, especially in some tumors like in lung cancer. Liquid biopsy, and I'm referring to liquid biopsy today to the free DNA or ctDNA, is part of this new technology that was coming and entering and actually approved by FDA. Using technologies as next generation sequencing, we are able to capture a rapid, with a rapid time to get the results, high concordance rate, also be repeatable over the time, and that is very important when we want to monitor in disease, and also the opportunity to capture this heterogeneity that we was talking before. Obviously, there are some of the things that could be false negative, and some patients are not cheaters. That was a big problem before when the technology was not sufficient evolved, but right now this is a minimal problem. It's still a problem for a minimal quantity of patients, and in those patients, we need to go obviously for a tissue biopsy. Heterogeneity, I'm referring not only to the intratumor, but also the intrapatient, and here some good definitions about also the clonal evolution and the inclusion of the idea of commutations that are very important also to distinguish the outcome of these patients in terms of progression-free survival and overall survival impact that these commutations can have. So nowadays we have the opportunity to include liquid biopsy in the whole patient journey. I will start with this part of the metastatic disease. And here, obviously, we need to remember, and that is a sad presentation, I would say, from ASCO. It's a sad reality that ASCO put us on front, that is the minimal patients that we are testing. So we have still only 50% of our patients, and if we are going to some groups of disparities, even lower the rate of the detection of these alterations or use of these technologies. I'm referring to tissue and liquid biopsy. So we need to do better because we have a plethora of drugs that are approved for different tumor types. Specifically in lung cancer was in a very prolific years. Were very prolific the last years in FDA approvals. So we have several new compounds, but we need to test our patients. So there are some studies like the Nile study who was giving robustness. You see here a very low opportunity to have all the biomarkers in one next generation sequencing because the tissue was really not enough in this real world data. But when we are using liquid biopsy, we have a high concordance, a high positive predictive value, reduction of the time, an increase of the detection by 48% when we're using the complementary approach. So using blood first, that is happened when it really is in the fact, this happened when we receive the liquid biopsy result before, is an opportunity. And that was investigated in some of the trials like this BFAST trial with several arms that we know already the results. I want to remind the first one, the ALK translocation. And in this study that was only using liquid biopsy for the source of the detection of the alterations, was having a very good success in the ALK translocation with an overall response rate very high, similar or even actually in a high proportion like the ALEX trial that was performed in tissue. In 2018, we published the first statement of the ILCC for liquid biopsy. And here we was talking about a sequential approach. That means after the tissue was not available for the first line treatment. And the first approach, or liquid biopsy as a first approach for patients who have TKIs treatment and they were progressing in order to identify mechanisms of resistance. Recently, in October of the last year, we published the new version of this statement paper. And obviously, beside the sequential approach, we recommended the complementary approach, that is using tissue and liquid biopsy at the same time. And this is a very important opportunity to capture all the information of the patients and have also a baseline for the monitoring during the treatment. Actually, some of the companies are using this combo, and so in the approval, so we have actually in some patients the opportunity to test that after 6 weeks of treatment with TKI, seeing this clearance of the alteration as a surrogate of the progression-free survival. Blood first approach is what I say is happening because we receive the results of liquid biopsy before and we start treating patients, but in some patients that they don't have tissue available is the only approach that we have. So applying also this to the early stage, and I'm referring to the minimal residual disease and adjuvant treatment, there are some approaches that are important. I would like to highlight two, that is the TracerX, that is a tumor-informed approach, and a tumor-uninformed approach that is the CAPSIG, that is using only liquid biopsy. Obviously, both of the approach are trying to give answers in the journey of this early stage in the patients. And the first one that is, as I say, a tumor-informed approach is departing from the sequencing of the tumor region, of the several samplings of the tumor, and creating this phylogenetic tree with clonal and subclonal information of the single nucleate variants, and reproducing that in liquid biopsy to have also this patient-specific phylogenetic tracking for discover the relapse of these patients. And as you can see here in this slide, there are several patients. That every graphic is regarding to one patient, belonging to one patient. So you can see that, for example, patient G have a recurrence of the disease at 44 days after the surgery. Other patients have during the chemotherapy, like the case of B, for example, or H, that the patient had not relapsed of the disease during the time. The CAPSIG is a technology that is, as I say, liquid biopsy. This is also was applied in unoperable disease, so in patients who receive chemoradiation or even inoperable disease surgery and chemotherapy. And you see that there are opportunities to detect ctDNA in patients post-surgery. These patients are going worse in terms of disease-specific survival and freedom of progression of progression-free disease. And also when we are integrating with the ctDNA analysis, there is a high concordance. So liquid biopsy is really a good tool to detect this recurrence. It's also an important tool to use in some of these alterations when we have, in some of these occasions when we have equivocal information from the images, and that is the case. Patients have a complete clearance of the DNA, but equivocal information that finally was related with a fibrosis and not a recurrence of cancer. So using these strategies of liquid biopsy, the pre or after even the surgery and after the treatment, we can have different applications. There are Right now, some data coming, for example, this is the Empower in adjuvant setting using atezolizumab. And this ctDNA positive in stage 2 or 3 population was defining groups to have a disease-free survival benefit. Also, there are trials like the Mermaid 1 and 2 that are ongoing, and they will be answering some of the questions that we have still on this setting. Going to another scenario, early detection or screening and cancer interception. Here also as a complement of the liquid biopsy of the low dose CT scan, tissue informed, like we saw, tissue non-informed as we saw, but also using leukocyte or methylation to avoid the clonal hematopoiesis are technologies that we have already here, near to be approved, single tumors or multi-cancer detection tests. They are raising some concerns regarding to the specificity and sensitivity for all the tumors, the kind of approach that one fit for all, and also the variables that we know already that are existing in different tumor types. So having this methodology of methylation, for example, the whole genome methylations in preliminary data of the discovery cohort was 34% in a specificity of 98%. And finally, and a high specificity, 99.5%, the sensitivity was really high, 51.5%. But we need to remember that not all the tumor types have the same sensitivity. As you can see here, in the case of lung cancer, we are talking about 74.8%, but we are including here cancer, no cancer, and in the cancer population from a stage 1 to a stage 4. So if we are looking for a specifically stage, in a stage 1 in lung cancer is 21.9% compared with 90% of stage 3. Different happened with other tumors like head and neck, where the sensitivity for early stage is higher. And if we are putting that in a context of the all interior population, early stage, so stage 1 is only 16.9%, so very low still for early detection. We have some difference in subtype that were not published in the last article, but we saw some preliminary presentations that were differences in adenocarcinoma and squamous, for example, in lung cancer, or variabilities when the hormonal receptor are positive or negative in early stage in breast cancer. So using also a model for methylation, but in a single tumor, this is the case of lung cancer, the combination of methylation and images, in this case radiomics, that was performed this study and presented in World Lung Cancer by 10 hospitals in China, was demonstrated the opportunity to detect small nodules with a high sensitivity. So this is a multi-omics approach that we can maybe see in the future as an opportunity for our patients. And finally, in the cancer interception, so the opportunity to capture the mechanisms that are involved in the creation of cancer, but also in the metastatization in the case of patients who have resected disease, will improve their survival rates in our patients and control cancer rates. So it's very important that we use these technologies. Some of the liquid biopsy family members, like exosomes, can be applicable for the cancer interception. We are working on that in our lab, and I hope that we can see some results positive in the future. So just to conclude, and obviously this slide showed that I am a data oncologist. You can see here that in the future we would like to have a brilliant future for liquid biopsy, including different members of the family, but also we cannot wait to be there. I hope that the doc is not coming back and say that there is people that is still not testing patients. So my final message is please use liquid biopsy or tissue biopsy. Important that you are using a molecular analysis for test your patients. Liquid biopsy is a great option because all the advantages that we was discussing. And also if you're interested in the topic, I leave here the data for our international society. We just finished our congress last year, annual congress, and there are a plethora of other educational activities. So you can join us there. You have our Twitter and my personal Twitter as well for any questions. So thank you very much for your attention. And,
Hello, my name is Jessica Hwang from the University of Texas MD Anderson Cancer Center, and I am delighted to speak about SWOG 1614 today and to speak about antiviral prophylaxis to prevent hepatitis B reactivation among solid tumor patients. We'll spend a bit of time talking about universal hepatitis B screening approaches, a little bit about the background and overview about hepatitis B as well. We'll move to study objectives and endpoints, protocol eligibility, study schema, and treatment, and we'll close with frequently asked questions. Let's begin by speaking about SWOG 1614 and move to the universal hepatitis B screening. ASCO recommends that all patients with cancer anticipating systemic anti-cancer therapy be tested for hepatitis B with 3 tests: the surface antigen, the core antibody, and the antibody to hepatitis B surface antigen. Patients with a positive surface antigen or a core antibody need further evaluation to prevent reactivation. Of note, ASCO recommends that large randomized studies are needed to determine optimal strategies in patients with solid tumor. And that's where I think this study, 1614, fills an important need. Hepatitis B infection is a viral infection of the liver that affects many people in the US. Up to 7% of people who were born outside of the US in high prevalence areas may be infected with chronic hepatitis B, and up to 30% of patients who are born outside of the US might be infected with past hepatitis B. This infection disproportionately affects vulnerable populations. Up to 3% of Asian Americans may have chronic hepatitis B, and some 18% of these groups might have past infection, and up to 10% of Black Americans may have past hepatitis B as well. Now, cancer treatments can cause adverse outcomes in patients with hepatitis B and cancer, leading to flares, reactivation, liver failure, and even death. But there is oral, daily, safe antiviral therapy that can be given concomitantly during cancer treatment to prevent reactivation and the adverse outcomes. Now, for patients with hematologic malignancies, there's clear and strong evidence to screen for hepatitis B and start antiviral therapy before and during cancer treatment. But that data doesn't really exist at that level for solid tumor patients, and there's not enough guidance and data to guide oncology teams about the management of solid tumor patients. So for this study, we'd like to determine whether prophylactic antiviral therapy is needed in patients with hepatitis B who are receiving cancer therapy for solid tumors to prevent serious health outcomes related to reactivation and to identify the optimal approaches to monitoring these patients. Let's go over to the study objectives and endpoints. There are 2 main study objectives. One is for chronic infection, and the other one is for patients with past infection. So first, we'd like to compare the effect of prophylactic antiviral therapy versus upon indication antiviral therapy on time to adverse liver outcomes of liver failure or liver-related death in patients with chronic infection. Secondly, we'd like to compare the effect of upon indication antiviral therapy versus usual care on time to adverse liver outcomes of liver failure or liver-related death in patients with past infection. Our primary endpoint is a composite of adverse liver outcomes made up of liver-related death or liver failure as measured by ascites, hepatic encephalopathy, or impaired hepatic synthetic function as measured by an elevated total bilirubin or INR. Other endpoints which are very clinically important include hepatitis B reactivation as measured by increases in hepatitis B DNA or a seroreversion of hepatitis B surface antigen from negative to positive. Other endpoints include a hepatitis flare as measured by an elevated ALT, as well as disruptions in cancer treatment or death due to any cause. We'll move to protocol eligibility, and we'll start by quickly reviewing what it means to have these test results come back and be positive, because it's essential for these patients who are eligible for this study to already be tested and known to be positive for hepatitis B. So patients with chronic hep B infection are known to have a positive surface antigen as well as a core antibody. Patients with past hepatitis B infection are known to have a core antibody that's positive, and they may have a surface antibody positive, and this one's protective. It's important to realize that the core antibody here must be an IgG or an IgN, a total Ig or an IgG, but not the IgM, because the IgM test would indicate acute infection. And for our purposes, we are interested to know whether patients have had past infection. Let's go over some of the eligibility criteria. So in general, patients must be diagnosed with a solid tumor malignancy, stage 1 to 3, but not carcinoma in situ or stage 4 disease. Other criteria listed below here. Importantly, any disease in the liver, whether it's liver cancer, primary, cirrhosis, or metastatic liver cancer, these patients would not be eligible. And patients with chronic and currently active hepatitis C are not eligible. And those with a history of HIV would not be eligible either. Patients who are planning to receive systemic anti-cancer therapy are eligible, if they are planning to have concurrent radiotherapy, that's allowed, but they must have discontinued all previous anti-cancer therapies at least a day prior to registration. Again, patients must have already been tested for hepatitis B and found to have chronic or past infection, and they must have a baseline hepatitis B DNA completed prior to registration. And importantly, these patients must not be taking anti-hepatitis B medication prior to registration or received it in the last 90 days. In general eligibility criteria listed here, importantly, patients may be registered within 28 days prior to the plan initiation of anti-cancer therapy, but we are allowing a bit of a window so that they may be registered within 42 days after the first administration of anti-cancer therapy. The total sample size is 444 patients. That's 222 in the chronically infected cohort and 222 in the past hepatitis B infected patients. These two cohorts would be analyzed separately, and all NCTN and core sites are eligible. And we do plan to stratify and analyze by planned cancer treatment. There are 3 anti-hepatitis B medications that are allowable on the study. These are standard of care medications. They're all oral drugs, and there's some adjustment for 2 of them, the tenofovir disoproxil and entecavir, based on reduced creatinine clearance. The tenofovir alafenamide, the first one, does not need to be reduced. All are pill form, daily dosing, and they must be started as soon as possible and up to 42 days after the initial dose of the anti-cancer therapy. Once they are started, they would continue up to 6 months after the last dose of anti-cancer therapy for a maximum of 24 months. Let's go over the study schema and the treatment. So again, these are all solid tumor patients with known chronic or past infection planning to receive anti-cancer therapy. On the left, cohort 1, these are the patients with chronic infection who would be randomized to either the prophylactic arm 1 or the arm 2 upon indication, where the antiviral therapy would be initiated only if the patient was found to have hepatitis B reactivation. In cohort 2 on the right, these are patients with past hepatitis B infection who are randomized to either arm 3, who would only get antiviral therapy if they developed reactivation, or arm 4, the usual care approach for the study site. Arm 1 patients who are chronically infected would be initiated on the antiviral therapy at the start of their anti-cancer therapy, and then would continue at 6 months after the last dose of the anti-cancer therapy, or a max of 24 months, whichever comes first. These patients with chronic infection would need long-term management, so our study team is available for guidance at the end of the study. The patients in arm 2 with chronic infection or arm 3 past infection who are randomized to upon indication, they would have close monitoring of their ALT, and if they develop a hepatitis flare, they would get a hepatitis B DNA. If they are found to have hepatitis B reactivation based on their DNA level, or a hepatitis B seroreversion, a hepatitis B surface antigen seroreversion, then they would start antiviral therapy. And again, similarly to the arm 1 patients, they would continue their antiviral therapy for 6 months or up to 24 months, whichever came first. And those patients in arm 2 with chronic infection would need long-term guidance, and our study team is again available for these patients at the end of the study as well. Arm 4 patients are patients with past hepatitis B randomized to usual care, and these patients, should they start antiviral therapy, they would start the therapy at the discretion of the initiating physician with any of the FDA-approved antiviral therapies, and the usual care would be recommended to be followed, either no antiviral therapies at all, antiviral therapies for all patients, or whatever is the usual care approach at that site. Let's move to frequently asked questions as we close this presentation. Our study was activated in 2019 and unfortunately was paused due to the COVID pandemic, but we were able to reopen in July of 2021. We have a lot of sites that are registered, and we are actively recruiting. We anticipate an increased interest and response to the ASCO recommendations for universal hepatitis B screening. We are very confident that screening tests are covered by insurance, and we've demonstrated that in a previous SWOG study 1204 as well. The antiviral drugs are not supplied by the study, and it will go through the standard of care process to obtain medication. I just wanted to leave you with my contact information if you have any questions, and certainly if your site has any eligibility questions or any guidance, our cancercontrolquestion@crab.org is the best email to use in order to get additional information. And with that, I'd like to pause and thank you for spending time with me to talk about hepatitis B and reactivation. And I really wanted to thank the state or the conference organizers for allowing me to present.
Good morning, and thank you for being here with us today at OncoAlert. My name is Dr. Nagla Karim. It is my greatest pleasure to present the updates on our S1929 study entitled Testing Maintenance Therapy for Small Cell Lung Cancer in Patients with SLFN11 Positive Biomarker. It is a personalized approach for therapy in extensive stage small cell lung cancer. We will talk about the hypothesis of the study, the background, objectives of the study, correlative studies, statistical considerations, and current accrual. PARP inhibition emerged as a potential therapeutic target in small cell lung cancer. High levels of PARP expression were noted by immunohistochemistry in small cell lung cancer and large cell neuroendocrine tumors, where PARP inhibitors started to be considered as one of the attractive novel therapies. And thus, the emergence of S1929 concept to utilize a novel therapy as a PARP inhibitor in the treatment of small cell lung cancer. In PDX models, talazoparib was shown to be the most potent of all PARP inhibitors in suppressing small cell lung cancer tumors. In addition, high schlafen-11 mRNA predicted the sensitivity to PARP inhibitors and chemotherapy in small cell lung cancer cell lines. So not only that we have a potent novel therapy, but also it comes with a predictive biomarker. In clinical trials, schlafen-11 was the top biomarker of sensitivity to talazoparib in small cell lung cancer PDX models. As shown, these were the high levels of expression of the schlafen-11 with schlafen-11 positive. It was correlating to the response to PARP inhibitors. And thus, a biomarker selected PARP inhibitor therapy was established, SWOG 1929, based on that scientific concept. The hypothesis of our study relies on that the atezolizumab and talazoparib combination is more effective as a maintenance therapy in patients with extensive stage small cell lung cancer and positive schlafen-11 compared to the standard of care atezolizumab when it follows the frontline systemic therapy of carboplatin, etoposide, and atezolizumab. This was based on several independent preclinical approaches demonstrating that the expression of schlafen-11 is a predictor of PARP inhibitor sensitivity in small cell lung cancer. Therapeutic advances in small cell lung cancer are of high priority, representing a significant unmet need of 35,000 patients newly diagnosed each year in the US. With the recent change in the standard of care to chemotherapy plus atezolizumab, it is imperative that we build upon this new backbone. Patient selection is a novel characteristic of our trial. Schlafen-11 predicted improved progression-free survival and overall survival in the valaparib and temozolomide combination cohort, where overall survival of 12.2 months in schlafen-11 positive patients were detected compared to 7.5 months in the schlafen-11 negative group of patients. And here the diagram showing the schlafen-11 negative IHC compared to the schlafen-11 positive diagnostic stain, where more than 1% is the cutoff. Schlafen-11 positive also status has been really shown in the subtypes of small cell lung cancer. As we know, with the new advancement of small cell lung cancer subtypes, A, I, P, and N, small cell lung cancer A subtype has shown sensitivity to cisplatin and PARP inhibition, where schlafen-11 positive A subtype cell lines were highly sensitive to cisplatin and PARP inhibitors. Co-targeting PARP inhibitor with the PD-L1 activated the STING pathway, leading to tumor regression. So as shown, increased cytotoxic T-cell infiltrate after the combination of a PARP inhibitor and anti-PD-L1 showed to be more effective as a synergistic mechanism. The objectives of the study were mainly primary objective comparing progression-free survival from the start of maintenance therapy among patients with schlafen-11 positive status. And the secondary objective were to evaluate the overall survival as well as the frequency and severity of adverse events in each treatment arm. And the translational medicine component will rely on banking the specimens for future correlative studies. The correlative study, the integral study, is mainly the SLFN11 positive, where 50%, around half of the patients with extensive stage small cell lung cancer are expected to have SLFN11 positive status, as seen in prior studies. The current data on SLFN11 IHC indicated that half of the patients, as I mentioned, are of SLFN11 positive status, where we estimate approximately 68% of the screened participants will initiate the maintenance treatment, leading to the fact that we'll need to screen 323 participants to get the goal of 94 randomized participants, where 10% ineligible rate might occur, leading to 84 eligible participants in our trial are anticipated, where 42 patients would be randomized to each arm. The accrual rate of 10 to 13 participants per month and 3 to 4 participants to be randomized each month to receive the maintenance therapy. With the schema of the study, we would start registering the patients and testing the archival specimens to the SLFN11 immunohistochemistry after cycle 1 of therapy, whether it's platinum etoposide or platinum etoposide and atezolizumab. At least 2 cycles of platinum etoposide and atezolizumab will be received. And patients can be then randomized in step 2, as long as they do not have disease progression, into arm A, which is the standard of care atezolizumab versus atezo plus talazoparib, until disease progression, with primary objective of progression-free survival, secondary objectives of overall survival, response rate, and adverse events. The translational medicine objective to bank specimens for future correlative studies. The integral biomarker, as I mentioned, is the SLFN11 IHC score. Eligibility criteria mainly would be for patients with extensive stage small cell lung cancer, SLFN11 positive status, no disease progression, measurable disease performance status less than 2 or equal to 2, asymptomatic and treated brain metastases are allowed as long as they're weaned off high-dose steroids. Prophylactic cranial irradiation and consolidation radiation are permitted in the study with normal organ and marrow functions, no live attenuated vaccines within 28 days prior to randomization. Dr. Hwang from MD Anderson Pathology gives us the support for the SLFN11 interpretation and testing. S1929 status, it was activated in June 2020 with a screening goal, as I mentioned, of 323, and basically to reach 94 eligible 84 patients. Up to date, step 1 screening happened in 178 participants with SLFN11 positive status in 106 of them. Step 2 randomization, we randomized 54 patients. So the screening status happened in 55%, randomization status around 64 or 57% of patients. Basically, the SLFN11 testing samples, median were like 6 days, and the results also happened in a median of 4 days. The screening accrual and the randomization, as seen, are very close to expectations. And that's the status that basically we had around 10-9 patients screened per month, randomized around 3-2 patients would be randomized per month. And that is close to the accrual goal. Here was one of the future on the horizon, personalized therapy for small cell lung cancer, looking into the different subtypes, but also having into the consideration, the SLFN11 being around 50 or even up to 70% of those patients with small cell lung cancer. It might be similar at some point to non-small cell lung cancer, looking into the PDL1 status and the other subtypes in the other disease. SLFN11 is being considered as an integral biomarker to select patients who will be eligible for enrollment in the study. Participants that have been detectable SLFN11 protein expression were eligible for enrollment. Basically, as we speak, the core biopsy, as well as the fine needle aspiration, not the smear, but the fine needle aspiration of significant number of cells to look into the SLFN11 has been obtained. And personalized approach in management of small cell lung cancer based on biomarkers may play a role in improving the clinical outcome of this difficult disease. All the acknowledgement goes to the team, a translational medicine team, Dr. Byers, Dr. Gay, and Dr. Recamp, and basically, of course, Dr. Karen Kelly, Dr. Lu, all our team here, and our pathologists and collaborators from MD Anderson. Thank you so much.
Hi, my name is Fumiko Chino from Memorial Sloan Kettering Cancer Center in New York, and I'm really delighted to give a presentation today about important updates from the last year in the world of financial toxicity. So financial toxicity is really a growing problem in the United States and in the world. And I routinely point to this ASCO opinion survey, specifically talking about cancer's financial problems, and to the finding that on the left, that there's actually slightly more people who are worried about the financial impact of a cancer diagnosis than from dying of cancer. And this really hasn't improved over time. So this is actually the most recent ASCO opinion survey from 2020. And what I found was that, you know, a cancer diagnosis is still causing significant anxiety for a lot of our patients, and that treatment affordability is an ongoing concern. When we talk about financial toxicity, what are we even talking about? Because I feel like it is a very commonly misunderstood term, and unfortunately is sometimes misused when we think about there are high costs to the healthcare system, to insurance, but financial toxicity is really a patient-facing problem. So the NCI defines financial toxicity as the problems that a patient has related to the cost of their care. They specifically note that people with cancer are actually more likely to have financial toxicity. In my own words, what I say is that, you know what, even with health insurance, there are these high costs of care that are really leaving some vulnerable families adrift in debt. And that some of these high costs are really having effects on quality of life and quality of care. Specifically, we know that financial toxicity matters in a lot of ways. So it decreases the quality of life that our patients face. It decreases their satisfaction with their cancer care, and ultimately erodes the quality of the care that they receive, including, for example, compromised care related to their medications or to their visits. I don't have the time in this short video to go through the whole extensive literature about financial toxicity, but I want to stress to you that this is a really pervasive problem, and it's really eroding a lot of the quality of care that our patients are getting. You know, we know that it increases certain things for our patients. It increases their personal and their family burden. We know that there are patients who are losing so much of work hours or their capacity to support their family, that they're actually becoming homeless related to the cost of their care. We know that it increases their risk of bankruptcy, and ultimately for people who are having high financial burden, it actually increases the risk of dying. The specific studies that I wanted to highlight in this video are 8 from the last year, and I really feel like they give a really nice, broad overview of the current work being done in financial toxicity, because we're really making great strides in terms of categorizing the problem, in terms of thinking about who is at particular risk of financial toxicity, and then actually thinking about how do we fix this? What are the potential solutions to financial toxicity? The first study I wanted to highlight is this study from Dr. Yabroff from the ACS group, and it's a really big picture overview of how much patients are burdened from a cancer diagnosis and how that burden is really durable over time. So this study really looks at kind of a big picture showing that the overall burden on patients is over $20 billion. And they specifically look at things like out-of-pocket costs, i.e. the thing you have to take out of your wallet to get your medication. And they also look at time costs, which has actually been previously very poorly categorized. So things like, for example, having to take off of work, potentially having to make an early retirement. So these kind of burdens that are harder to categorize, but actually are quite meaningful to patients. And they broke it up into age groups. And I think unsurprisingly and consistent with prior literature, they found that younger patients have bigger burdens for both out-of-pocket costs and their time costs. And then specifically over time, they found that some of these costs are really durable. They go down a little bit, but they're still present even maybe a decade after a cancer diagnosis. And I think this is really important to highlight, that financial toxicity can be really a survivorship issue. Some of these costs, some of these burdens, they can really follow people for even years and years after their diagnosis. Switching gears, this study was actually just came out last week from Dr. Shankaran, and it was published of the SWOG study, which looked at a longitudinal assay of people who had metastatic colorectal cancer, and what they found was that this cohort of patients really had incrementally increasing financial hardship. And they actually looked at objective measures of financial hardship. So things like, for example, having to refinance your home, having your income decline, having new loans or new debts. And they did sort of an aggregate measure of any major financial hardship. And what they found was that essentially 3/4 of the group by 1 year actually had some financial hardship, and that there was real quality of life, social functioning decreases if you had early financial hardship. And this study was really fantastic in that it really followed, and you can see as the numbers go up 3 to 6 to 9 months, that the burden only increases for those patients who are on treatment. Another study from one of my colleagues, who's Dr. Avicki from MSK, full disclosure, I am a co-author on this study, specifically was looking at how again, objective financial toxicity, for example, having a payment issue and needing financial assistance, how it could be potentially related to our own healthcare utilization. So for example, in this study of over 4,000 patients at MSK, we found that actually patients who had more imaging, more visits actually had an increased risk of objective financial toxicity. And that about 1/4 of our patients had this. And most of them were in payment issues, meaning they had 2 or more bills sent to collections. This is really interesting because it does potentially point at an area of maybe intervention. So maybe we're doctoring patients to death. This multivariate analysis that found this did control for things like stage and race and insurance. There may be some things that are uncontrolled for in the analysis. Obviously, we always are concerned about that, but it does really it points to maybe thinking about what the provider role is in improving financial toxicity. The next study I wanted to highlight was specifically a study looking at how financial toxicity and healthcare disparities, and in specifically vulnerable populations like minoritized groups, can really be kind of interrelated. And this study looked at a national cohort from the US HINTS survey, which is a cross-sectional survey. And they found that specifically Black patients are actually much more likely to have problems with their health insurance after a cancer diagnosis. And they were more than twice as likely to report being financially harmed because they had a cancer or cancer treatment. And so this study showed, again, something that we've kind of known all along, which is that financial toxicity and access to care in vulnerable populations is really interrelated. The next study I wanted to highlight was specifically about the effects on vulnerable populations from the pandemic. Again, full disclosure, I am an author on this study. And what we specifically did was actually ask AYA survivors, so patients who were diagnosed and treated with cancer before the age of 40, a group that we already know is sort of enriched for financial toxicity, how specifically the COVID-19 pandemic was affecting them. And what we found is that there was an incredibly high rate of negative economic events related to the pandemic. So for example, people losing their job or having decreased job security or not, being furloughed. And unfortunately, we found about 2/3 of patients had reported some negative medical cost coping behavior, meaning that they were either skipping appointments, skipping out preventative care, not seeing their specialists when they should have, et cetera. And I think this study sort of highlights that in a vulnerable population susceptible financial burden, COVID-19 really added that extra layer that made it even more difficult to just survive, much less go to, your cancer follow-up. The next study, I think, is really telling. And it's something that was very shocking to me when I read it. And it's a small study. It was qualitative interviews of physicians that were in Kentucky. But I felt like this study was really important in thinking of the other perspective. I live in a financial toxicity world. I'm constantly saying, oh, we need to have cost conversations with our patients. We need to think of solutions, including opening dialogues with our patients so that we're aware of their concerns. And what this study showed is actually 2/3 of the people they talked to said that cost conversations were not in their best practice idea. They specifically avoided having them. And some of the reasons for avoiding having cost conversations were, again, really stunning to me. One person said that, if you start worrying about costs, then you're not really worrying about the patient. And you have to present what's best for the patient, that's your job, and that the cost is not your job. Meaning that they think that if you ignore the costs, that's how you're taking best care of the patient. Another physician said that, going through cancer treatment is hard enough. I want my patients to take care of themselves. I don't want them to be constantly stressed out about money. And that was a reason why they didn't have cost conversations with their patients. Again, shocking to me because we know that cost conversations can help reduce costs for our patients. But I think, again, it's the other perspective, and that's why I found this study so interesting. Moving on to two studies that are going to highlight potential solutions for financial toxicity. This study came out of the Duke group from Dr. Safar's group, and it was evaluating the role of a app-based financial navigation program. And this study was really interesting because it actually did not meet its primary or secondary outcomes, meaning they were trying to document that the app could help lower costs, could help lower financial distress. They couldn't find those because of poor follow-up survey data. But what they did find, and I think this is really encouraging, is that the app really did help people navigate to financial solutions. And they found an appreciable increase. And for people who were randomized to receive the app, that they both applied for and received financial assistance. So essentially tripling the rates of those patients who applied for and received financial assistance. So again, even though it didn't meet its primary endpoint, I think this study is actually quite promising in that it shows that something like an app could really improve how patients actually are able to afford their healthcare. The last study I wanted to highlight was about the Levine Cancer Group and their financial toxicity tumor board. So this study was pretty revolutionary in that it outlined how the Levine Cancer Group was specifically gathering together people who were invested and interested in supporting their patients through their cancer treatment, including specialists in, heme onc, radiation oncology, surge onc, social work, nurse navigation, pharmacy, all of kind of interested parties. And they would meet once a month to actually review difficult cases, just like a tumor board would meet. And what they found was that there were common problems that kept coming up, and it spurred them to really think about novel, innovative solutions within their own cancer center to fixing some of these problems from some of their patients. And I think it's a really great model for healthcare centers and cancer centers who are trying to kind of build up system solutions to try to help manage their patients who are having financial difficulties. And what they found in the 2 years that the tumor board was in function is that they were able to actually get a lot of assistance for drugs for their patients and a copay assistance. And they were actually able to help a couple thousand patients through this financial toxicity tumor board. So I think this actually has like a lot of very, very, very important promise in terms of potential solutions. I'll just summarize kind of the big picture for financial toxicity, which is, I think financial toxicity is really a multifactorial problem. And I think, the blessing and the curse of that is that there are many potential solutions. And so we can really think about this from a policy level to a provider level to a patient level, and think about there are solutions each step of the way from, US government rules all the way down to the patient in front of you. I also want to highlight that we are all responsible for financial toxicity, from medical oncologists, surgical oncologists, radiation oncologists, diagnostic radiology. We can all contribute to the relative costs of care for our patients. And then what I'll say is that this is an ongoing problem for our patients. There are things that continue to cause financial toxicity for even cancer survivors, thinking about, ongoing treatment or surveillance, thinking about health insurance disruption to work, chronic effects and, depleted savings. All of these things contribute to ongoing burden for our patients. This has been a whirlwind through financial toxicity from 2021, and I'm so grateful that you've been listening to me for this, and I really appreciate your time. I hope you have a happy and healthy 2022. Thank you.
Hello, everyone. My name is Dr. Narjust Duma. I'm the Associate Director of the Cancer Care Equity Program at Dana Farber Cancer Institute and a member of the faculty at Harvard Medical School. It is my true honor to be with you here at the OncoAlert Colloquium that's being supported and sponsored by many groups across the globe. Today, we're going to talk about equity and cancer in 2021. It's hard to come with all the data that has come about equity during 2021, but we're going to talk about some relevant information as well as some high-level data. It's important to mention that equity is not only an issue in the United States. Equity, or the lack of equity, affects many countries in the globe. We see it about border help in West and East, Europe and Africa and Australia and Latin America. So some of the things that we're going to discuss applies to all those populations, and I hope this can be helpful to you. First, it is important to mention that not everybody has the same access to care. Some people may have a direct pathway to the hospital, a direct pathway to their doctor. But for other people, like you can see it in the other side of this graph, it can be a very convoluted and a very complicated road. When we see patients in the clinic, sometimes we forget that some people may have taken a driver to see you, and other people may have taken 2 or 3 buses to come and see you. And in some parts of the globe, it may require several days for them to see their oncologist and travel, taking a bus, taking a ferry, or flying due to the challenges of having a specialized care in some areas of the globe, particularly in rural United States, in some parts of Brazil, and some parts of Africa, in which the next oncology center is hours away. As we talk about cancer and equity, it's very important to mention that clinical care for health outcomes only accounts for 20% of the health outcomes. So health outcomes are divided between the length of life of a patient, that's 50%, and the quality of life of a patient, that's 50%. But there's several factors that affect that health outcome. So one of them are social determinants of health or social economic factors, that's 40%. That's education, employment, income, family support, and community safety. Then we have a physical environment, access to water, access to transit, access to housing. And then we have health behaviors, tobacco, diet, alcohol, and sexual activity. All of that accounts for 80% of healthy outcomes, with clinical care only accounts for 20%. So when somebody is sick with cancer, 80% of what is affecting a health outcome has nothing to do about how long they wait and the waiting room or about your care. But you as a doctor, a healthcare provider, or any person has the power to generate equity to help with these outcomes. So we talk about around 50% of these factors are external and they're associated with the patient's environment. These are known as social determinants of health, which includes community access, healthcare, access to healthcare. Is it a supermarket available? Are you living in a food desert? So a food desert is when it's very hard to get fresh fruits and vegetables within a ratio from your house or apartment. Also your level of education. And we know for cancer, health, education, and income are directly associated with stage of diagnosis. In the case of lung cancer and breast cancer, the lower the socioeconomic status, the more likely the patient is going to be diagnosed as stage 4. And these two cancers have screening modalities, a mammogram for breast cancer and lung cancer screening for lung cancer. So the greatest predictor of health is social determinants of health. And I'm talking about this because I want you guys to see health equity not as something that's add-on or something that is on fashion right now, but it's 80% of your patient's outcome are determined by external factors. And of that 80%, 50% are social determinants of health. So we call these unnatural causes. And these natural causes are making us sick. They're making us sick because patients don't have access to healthy food. They don't have access to education. They don't have access to transportation. And this applies to many people in the globe, particularly to immigrants, particularly to minority groups, for refugees and patients that are, or groups that have been historically discriminated, that like the LGBTQ community, as well as patients that are incarcerated. So these unnatural causes, they're making us sick. I'm going to give you an example how this is so important. So we have a patient that is a male, 65 years old, no small cell lung cancer. Next gene sequencing was done and did not show a target mutation. PD-L1 is 100%, and we feel so excited about that. His performance status is adequate at 1. Unfortunately, the patient has no transportation to the cancer center to go and get that very fancy immunotherapy, pembrolizumab or atezolizumab. So despite the patient having the clinical characteristics to be a good candidate for therapy, he doesn't have a way to get to the cancer center for the infusion. So it doesn't matter if the patient has a target mutation, if he has a PD-L1 or 100%, your response rate is still going to be 0% if the patient has no transportation to the cancer center. So these are a very good example how the social determinants of health affects health outcomes. So the determination is that the patient was lost to follow-up, when in fact, the patient was not lost to follow-up, he just didn't have access to transportation. And your response rate was 0%. So we conduct very large, intricate clinical trials to improve the survival of our patients. But even if the drug is approved, the patient still doesn't have transportation, so your response rate still will be 0. The NCI defines cancer health disparities as differences in the incidence, prevalence, mortality, and burden on cancer and related adverse health conditions that exist amongst specific populations groups. So certain groups in the United States or outside the United States are at higher risk for cancers. We know that Hispanics are at higher risk for infectious-related cancers, gastric cancer, cervical cancer, HCC or hepatocellular carcinoma. We also know that other groups are at higher risk, for example, women in India that have to cook indoors are at high risk for lung cancer. And also the mortality is very high in low socioeconomic status, regardless of the country. These patients are less likely to be able to afford therapy or even just come to therapy. Even in settings in which is universal healthcare, disparities still exist. Cancer health disparities in 2021 has been described in all these aspects. The disparities have been described so many times over so many years. There is cancer health disparities in incidence of certain cancers, stage of diagnosis. We know that gender, race, socioeconomic status, geographic location, we affect the stage of diagnosis. Mortality, higher mortality in certain groups. In certain areas of Africa, patients that are diagnosed with lung cancer get no treatment. So the mortality is extremely high. Survivorship issues, they're less likely to follow up with primary care. They have less likely to have access to survivorship needs. Screening rates are very low in certain groups all across the globe, and access to clinical trials continues to be an issue. These are only a few of the disparities that has been documented in 2021. Some of them have widened during the time of COVID-19. Let's look at this as a global equity issue. One of the big challenges about equity is that we only focus in little areas. And we see this as a problem of the US, a problem of Brazil, a problem of Spain. No, cancer equity is a problem, it's a global problem because there are many inequalities for these patients to get care. So the global equity issue, refugees' health, these patients are less likely to get any cancer screening or any health care. And even if they stay in the country for a longer time, they're also unlikely to receive appropriate care. Many of them are waiting for documentation of immigration status so they cannot get health care in the setting of universal healthcare systems. Border health is also a big issue. There are issues between Mexico and the United States border, between the border of Mexico and some other Central American countries, between the border of Venezuela and Colombia due to the humanitarian crisis in Venezuela. Low and middle income countries have many issues. We can get these very fancy drugs approved, but in some countries like in Africa, osimertinib is not available. Gender-based disparities, women are less likely to be diagnosed on time, and they're also more likely to be suspected to have a gender-specific cancer. And this is particularly for lung cancer, which many women face delays in diagnosis. And access to drugs in clinical trials continues to be an issue. We continue to do these clinical trials in very high-income countries, US, Canada, West Europe, and Japan and China, when in fact most clinical trials do not recruit in low to middle income countries. So this is just a few of the challenges we have of cancer equity globally. Not everybody has access to the same. We're going to talk about a few abstracts that were presented in ASCO 2021 that are related to cancer equity. One is about the racial differences in biomarkers testing for non-small cell lung cancer. As some of you may know, 50% of the patients with non-small cell lung cancer may have a target mutation, and this includes KRAS G12C that receive a drug approval this year. So the objective of this study was to understand if there are differences in testing for NGS or biomarker testing and enrollment in clinical trials among patients with non-small cell lung cancer. So Dr. Bruno reviewed the data from Flatiron between January of 2017 to October of 2020. Around 800 sites of care were identified. This is the study cohort of how data was evaluated, and the final cohort of non-squamous histology included over 10,000 patients diagnosed between 2017 and 2020. They were treated within 120 days from diagnosis. Most of these patients have the eligibility criteria included no synchronic metastatic cancer, so no other cancers, and no death within 120 days. What the study we're summarizing shows that there were racial differences. So for white patients that were ever tested for next gene sequencing were 76.4% versus 73.6% with Black patients. In addition, this is ever tested for genetic testing, and for NGS, which is more broad spectrum, was 50% in whites versus 39.8% in Blacks. And most patients were tested at first line therapy, but this was significantly higher in whites. So we saw a racial difference between NGS testing in these patients in the United States. So the studies concluded that real-world practice patients are Black are less likely to undergo NGS testing. And that was correlated also that these patients were less likely to go into clinical trials. So if the patient doesn't get NGS, it's very hard to find a mutation that may have an ongoing clinical trial. So by the lack of testing of these minority patients, we are reducing the possibilities of there to get target therapy, and we are reducing the possibilities again to go into a clinical trial. So Dr. Bruno showed that racial disparities exist in report to NGS testing in the United States for non-small cell lung cancer. There was no data provided regarding Hispanics or other subgroups, but we know that for Asian patients, they tend to get tested equal or higher than whites. So another abstract that really caught my attention was this abstract about what accounts for racial disparities in survival for estrogen receptor positive axillary node negative breast cancer in the United States. This was presented by Dr. Hoskins. So their study evaluated, what is really affecting these disparities and determined that social determinants of health, what we just talked early, this proportional aggressive tumor biology, which is common in Blacks and African Americans with triple negative breast cancer, but there's also seen with estrogen receptor positive, accounted for 60% of the disparities unexplained by the Sears Oncotype database. So even in the patients that had an oncotype that about the cancer and that in a spectrum of breast cancer, estrogen receptor tends to have a better outcome, this patient had a worse outcome that was determined by the social determinants of health. And this goes back to the graph that I just showed them early, is that 50% of our patients outcomes are affected by these social determinants of health. So you can get all fancy with genetics, but we still have to take into account the environment and the external factors when we talk about cancer equity. We can now move forward without talking about how COVID-19 has affected cancer care, particularly cancer care equity. The COVID-19 pandemic has disrupted the spectrum of cancer care, including delays in diagnosis, treatment, and halting clinical trials. We still don't know the full spectrum of the consequences of COVID-19, but we do know that disparities widened or worsened during the times of the pandemic. One of my mentees and I, Dr. Alanza Gasti, now at the University of Miami, wrote this editorial in April 2020. And unfortunately, this editorial continues to be true a year and a half later. That when we listen to the news, we continue to hear, oh, we're in the same waters. This pandemic is affecting all of us. It is affecting all of us, but it's not affecting all of us the same way. Some of us have the privilege to stay at home and work from home, with many minority groups in the United States and outside of the United States couldn't stay at home because they were at grocery stores, they're part of transportation, part of janitorial services, and the hospital. While we are in the same waters, we are not in the same boat. Some people during the pandemic are in yachts, some other people are in sailboats, and some other people are in river rafts or they are drowning during the pandemic. So we still don't know the disruption, but we know that all these disparities had worsened during COVID-19, as the majority of people of color have been highly affected by it. So why are these disparities widening? Well, there are many things. There is loss of job or economic insecurity already in populations that have low socioeconomic status. For some populations, for some families, it's not possible to stay away when you have a large families in very small space. Many patients are dependent on public transportation. So when public transportations were limited, how they're going to make it to the cancer center. High contact jobs, as I just mentioned, grocery stores, bus drivers, and the digital divide. We forget that having internet, a broadband internet, is a privilege, having a smartphone or having a computer. So we're trying to talk about telemedicine, but that actually has widened the gaps. One example of that is in rural United States, in which internet may not be reliable. Patients don't have the technology literacy to do visits online. There's also a lot of fear, as many of us have family or self were affected by COVID-19. So all of this is only expected to worsen the cancer health disparities that we know. Abstract that was presented at ASCO 2021 that really caught my attention is that disparities regarding end-of-life care has worsened during the pandemic. So the investigators look at patients that die at home versus the hospital during the pandemic, and they noticed that Medicaid patients, so these are patients that get insurance from the state here in the United States, are more likely to die at home without hospice during the pandemic versus people with commercial insurance that were dying at home on hospice. So what the investigators did is they looked at 610 patients pre-COVID and post-COVID to determine who was dying where. So the place of death, 41% die at the hospital, 37% die at hospice or a home facility for hospice, and 22% of patients are dying at home without hospice. So when the investigators look further, they find out that more people were dying at home without hospice now than during the times of pre-COVID. And this is particularly unique to patients with Medicaid or low socioeconomic status. So the summary of this study is that before COVID-19, Medicaid patients were more likely than commercial patients to die in the hospital, right? So patients usually don't have resources to go home on hospice. But during COVID-19, Medicaid patients were more likely than commercial insured patients to die at home without hospice. So we're failing these patients that are dying at home, something that's fully covered by Medicaid and Medicare, without hospice services. And it's important to mention that hospice services not only help the patient die in a more comfortable way, but also helps family cope with the loss. And as we're talking about the health divide, COVID-19 has increased this divide. I think trying to pursue digital health and telemedicine is important, but we sometimes forget that many patients have different barriers. One of them is language barrier, and I'm a big advocate that even if you speak un poquito de español or just a little bit, is not enough. Tenemos muchos problemas con la telemedicina en los pacientes que hablan un idioma que no es inglés. So I just spoke to you in English to see how you feel about no understanding when somebody's talking to you. And that's what many patients face when trying to talk to their providers and there is not an interpreter available. We cannot forget that telemedicine may not be an option for everyone, but we have been trying to force it in patients that have language barriers, have health literacy limitations, or just don't have internet, or it can be a big financial burden to have a telemedicine encounter with your doctor. Finally, one of the challenges we continue to observe is the lack of diversity in the workforce everywhere. This is a global problem. So we have providers that don't look or sound like their patients. So we need to continue to work in mentoring, sponsoring, recruiting, and including people from diverse backgrounds into all healthcare professions, not medical school, because that would be a way to generate cancer equity. But my final question to you is, how do we measure systemic racism and discrimination? That's one of the hardest questions. A lot of aspects of physician bias, a lot of things that exist within our healthcare systems around the globe continue to exclude our patients, and they're the basis of systemic racism. But it's time to talk about interventions. It's time to have meaningful actions. And all of you have a lot of power to generate equity in cancer care. And as we start 2022, I want to encourage all of you to use your privilege to create equity. I hope that eventually this talk about cancer care equity will be outdated because the problems will exist. But it's time for us to take action. It's time for us to care equally about all patients. So thank you so much, and I hope you continue to enjoy the colloquium, and thank you to OncoAlert for the invitation to present. Have a wonderful day.
Such a pleasure, and thank you so much, Dr. Gil-Morgan, for your remarkable effort in bringing the global oncology community together for this remarkable educational venue. I will always fondly remember our first two conferences in 2019, where the OncoAlert faculty quickly became the top conference influencers. Now let me review with you major development in cancer and COVID-19. Here are my disclosures. Our COVID-19 research was all a voluntary effort. We have very densely filled minutes in front of us to cover all key aspects. Therefore, in the interest of time, I will move on and let you review the slide at your own leisure. The problem is major. COVID-19 is now the third leading cause of death in the US for 2020. With ever new variants emerging, it is good to review patient outcomes prior to vaccines. Where did we start? Amazingly, a resident and now Star Mayo Fellow, Dr. Akash Desai, who just also received his ASCO Young Investigator Award, heard several of us on Twitter discussing starting cancer registries. He brought us all together in a tweet, and the rest is somewhat already history. Dr. Jeremy Warner and I, along with colleagues, hashed out core variables for the database together within the first 2 months, literally by email back and forth. He and I then ran these variables by key early CCC19 investigators and received further refinements by various disease specialties. And then Dr. Warner quickly coded the necessary VETCAT. Special shout out to our heme malignancy colleagues. Through social media, we alerted our key colleagues around the country, and amazingly, within a few weeks, we had over 100 institutions volunteering their time. To remind you, we also found a high use of hydroxychloroquine in nearly a third of patients. We had a broad US patient population distribution at CCC19, weighted by COVID hotspots early on during the pandemic, and 5% of patients from Canada and 7% from Spain. I also want to point out a very common misconception that 1,000 patients across all major cancer types provide enough statistical power to answer all clinical questions and find all risk factors. Fortunately, that's not quite the case, but clearly it can answer a lot of questions. In the interest of time, I just want to highlight here that we a priori selected variables to truly focus on validating prior suspected risk factors for this first large-scale analysis. Most common symptoms were not surprising: fever, cough, fatigue, malaise, and dyspnea. The median age was 66 with an even gender distribution and good representation of key minority groups as well. The most common tumor types were not surprisingly breast, prostate, GI, lymphoma, thoracic, and multiple myeloma. We did have enough statistical power to confirm the following main risk factors for 30-day mortality: age, gender, smoking status, performance status, cancer status, especially progressing disease. And given the high use of hydroxychloroquine in about a third of patients, despite major confounding by indication, which makes a drug efficacy estimate inaccurate for clinical use, which we clearly specified, we did decide to analyze it in general to assess if we see an obvious therapeutic benefit, and clearly no obvious benefit was observed. Active comorbidities, defined as requiring active medical intervention, were particularly associated with severe COVID-19 as well as mortality. That is, comorbidities require at least drug therapy, even after adjustment for other known major COVID and cancer poor prognostic factors. Interestingly enough, this near linear increase in mortality by increasing number of active major organ comorbidities is not that dissimilar to the impact as seen on febrile neutropenia mortality. I also want you to remember this hazard ratio of 1.8 with one comorbidity and in the 4 range with 2 comorbidities. How do these findings translate into actual mortality percentages? With 2 comorbidities or greater, the risk of death is nearly 20% or beyond. Conversely, however, even early on in the pandemic, mortality was only about 2% in patients without any major comorbidities. These patients are clearly at much lower risk. Overall, across all cancers, the 30-day mortality was at 30%, and with full follow-up, in a follow-up Lancet letter at 17% once follow-up data matured, and very similar rates of ICU admissions and ventilator needs were seen. 26% of patients experienced the composite outcome of severe COVID-19, with 44% and 50% of patients had an oxygen need or hospitalization. Among patients with poor performance status at time of COVID-19 diagnosis, over 1/3 died. Older age patients that require intubation, nearly 60% of patients died. In patients with poor performance status who are intubated, the same time had an 85% mortality on average. Clearly, these patients have very poor prognosis. Dr. Grievous then presented the updated numbers at ESMO with nearly 4,000 patients, and therefore could expand the analysis to additionally planned variables and clearly identified hematologic malignancies as well as recent cancer systemic therapy clearly as additional risk factors. Patients in remission on average are clearly at quite lower risk compared to other active cancer patients. TerraWorld, an early lung cancer spin-off of CCC19, now a separate global registry with over 1,000 patients early on already. The team confirmed chemotherapy as well as a risk factor for mortality. And note the comparator group here is still patients on other therapies that may also have additional risk for mortality. And since other studies have also shown chemotherapy as a risk factor, which we'll briefly review. They also find prior steroid use as a potential risk factor, but caveat, this could be invert due to other COPD-associated comorbidities or other steroid-associated comorbidities. Several of these studies here also confirm chemotherapy as a risk factor, but yet the exact risk ratio remains somewhat uncertain at the time, and we need to caution many adjusted prognostic confounders often remain in studies, including for CCC19, which may lead to an underestimate of the drug therapy associated risks. What is clear though, for the neutropenic period, most studies still have suboptimal laboratory data completion as well as collinear chemotherapy in the same model. How about immunotherapy by itself, as listed here? Most studies did not find a signal. This is clearly encouraging news in the small study with potentially major imbalances in prognostic factors may give us false positive findings. Dr. Grievous and Dr. Kaki, in an exploratory drug regimen analysis, found the strongest 30-day mortality signals for R-CHOP-like anti-CD20-based therapy, the combination of platinum and etoposide, as well as DNA methyltransferase inhibitors. It's good to remember that for many drug regimens, we still only have a few patients in the registry, therefore exploratory nature here. What is clear, the risk of contracting COVID-19 infection are greatest and multifold in patients with a recent cancer diagnosis, as analyzed here within the first year. After that, the risk for many appears to normalize for most settings close to the general non-cancer population. And Dr. Hwang and team showed similar multifold infection risks for most solid tumors. Outside of CCC19, we also performed a meta-analysis of all major cohort studies reporting on COVID-19 mortality. Hospitalized patients on average had a 30% mortality rate, and mixture of outpatient and hospitalized studies, the mortality averaged around 15%, exactly where CCC19 ended up. And in studies with the majority of solid tumor patients, the mortality on average around 26%, and active hematologic malignancies up to 40%. Of note, some of these were in areas such as Europe that had early on very overwhelmed healthcare systems. We have large-scale US insurance claims data now from Optum, just recently published in JAMA Oncology. This is a US nationwide insurance database. They assessed over 500,000 patients overall, over 14,000 patients with cancer, in over 490,000 control patients without cancer. They confirmed that the presence of an active comorbidity, here the presence of a medical claim functions as an actively managed comorbidity, has an increased risk of death at 30 days of nearly a hazard ratio of 2, again at 1.8, and 2 or more comorbidities of nearly a hazard ratio of 4. It's just nearly identical to what we've seen even early on in the pandemic in our Lancet paper. Compared to the Midwest, they also identified the South to have a near doubling of the mortality risk. And most importantly, despite still some limitations of missing major cancer prognostic factors, the risk from chemotherapy within 3 months from COVID diagnosis is nearly double. Chemoimmunotherapy has a hazard ratio of greater than 2, And they saw near identical results when limiting these analyses to patients with solid tumors. Anti-lymphocyte or transplant CAR T-cell patients clearly have an increased risk. The good news is immunotherapy and endocrine therapy does not appear to increase the mortality risk. Importantly, with the sample size, they could also drill into the specific age groups and see hazard ratios in the 3s for age group 60s and early 70s, and a hazard ratio increase of 6 to 7 for the late 70s and early 80s. It might even rise steeper in the late 80s and beyond. The study also confirms that hematologic malignancies have an increased mortality risk, as well as patients with solid tumors with a hazard ratio of greater than 2. And these data also confirm again our previously identified risk factors, which are not shown in the interest of time. How about cancer-specific numbers? Early on, unadjusted numbers from CCC19, we saw about an 8% mortality in breast cancer on average and 26% for lung cancer and 20% for most solid tumors. Since then, we have had the meta-analysis from Dr. Tagliamento and colleagues for breast and lung cancer, summarizing on the right, a roughly 9% mortality across all larger breast cancer studies, and about 22% mortality in the larger lung cancer mortality studies. Looking at the Optum outcome, 30 mortality outcomes data assessed by cancer type, solid tumors on the left in blue. The following cancer types have a hazard ratio of nearly 2 or above. That's like colorectal digestive cancers, lung, melanoma, and CNS. Urinary tract cancers have an odds ratio of about 1.4. A prostate, other male genital, and colorectal cancer do not appear to have an increased risk compared to breast cancer. In red on the right are the hematologic malignancies compared to acute leukemias. On average, most appear to have a more favorable risk profile compared to leukemias. Or similar, such as MDS, although more detailed analysis into traditionally higher risk drug regimens will be helpful here as well. Recent cancer treatment clearly puts patients at greater risk as well. How about disparities? Clearly, Black race is a major risk factor both for severe COVID-19 as well as mortality, especially in non-cancer patients on the right as well. COVID-19 has shone such a haunting spotlight on substantial higher mortality in Black patients in general, in particular for COVID-19, which we discuss in our JAMA Oncology commentary on the study. This is unlikely due to biologic factors, but rather explained by somewhat the elephant in the room, the major differences in social determinants of health and other disparities, such as less ability to socially distance, being frontline workers, reliance on public transportation, crowded living conditions, and even challenges to afford quality masks and ready access to healthcare. We also discussed the hints of substantial reduction of disparities with reliable healthcare access, which is probably also quite the case for several cancer patients. And very consistently, this over 7 million EMR database in 2020 showed very similar overall mortality rates compared to CCC19. How about patient outcomes over time during the pandemic? The UK Onco team presented at ESMO that they saw trends towards improvements in overall survival from 30% to, again, ending up at that 15% range towards the end of 2020. They also saw improved time to diagnosis from 4 to 1 day from symptom onset. The Optum team also saw similar improvements, especially in terms of hospitalization, even for these actively treated cancer patients. How about these concerning venous thromboembolism numbers that we heard of in COVID patients? Clearly, even non-cancer patients are at substantially increased risk. Even unscreened ICU patients that are without a cancer diagnosis but COVID-19 have a 20% VTE risk or greater. We developed at CCC19 VTE data, the COVID-19 thromboembolism score, TE score, which includes the following risk factors: cancer type by Corona score, venous thrombosis history over a lifetime, ICU admission, on hospitalization admission, recent systemic cancer therapy, ethnicity, we did not have enough data for Asian population and an elevated D-dimer exploratory analysis. The low risk group then ends up at 4%, and the high risk group, not just limited to ICU, ends up at least at 11%. Can we predict venous thromboembolism in COVID patients as outpatients? How does our Corona score perform? Dr. Lyman's team developed this in collaboration with Dr. Corona. Dr. Lyman just completed his methodology training at Oxford during a sabbatical with Dr. Altman after his initial Harvard time. And we had a large prospective cohort study with over 4,000 patients to validate risk factors for febrile neutropenia, unfortunately also assessed venous thromboembolism. And Dr. Garana had just left the laboratory as a first-year faculty and had focused on cancer-associated thrombosis, was a great collaborator to really help us focus on the right risk factors to validate. Our Corona score is now validated in over 20,000 patients across numerous prospective cohorts, as well as phase 3 clinical trials, including Dr. Francis's NIH FACT study that we collaborated on, as well as the Cassini and New England Journal Thromboprophylaxis randomized trials. And Dr. Jimenez and Munoz-Martin presented interesting data at ITSTEC 2021, suggesting our Corona score also predict venous thromboembolism in cancer outpatients with a COVID-19 diagnosis. Very little is known about the long-term sequelae of COVID-19, especially in cancer patients and patients with cancer. Dr. Cortellini, unfortunately, recently presented at ESMO interesting data with approximately 15% of patients experience a long-term sequelae, and more than 20% of patients in the UK and some European countries that discontinued their cancer therapy. How about the impact of cancer care on telehealth during the pandemic? The WHO Rapid Assessment of Service Delivery by the end of May in 2020 assessed over 120 countries, and in orange found countries with partial disruptions, and a few countries in red and highlighted here for the cancer services were fully disrupted. I do not need to remind this audience about the major disruption of acute disruption of cancer care, especially early during the pandemic. How does this translate to patients? Dr. Sadish reports care impacted by COVID-19, here denoted in red, and by non-COVID factors, here denoted in yellow. For a major New York City cancer center, from the left to the right, you see in the graph the impact on systemic cancer therapy, imaging, intervention radiology, radiation therapy, and surgery. Dr. Weber and team elegantly show us how telehealth, in blue, has substantially reduced use for our Black patients versus other racial groups. Overall, telehealth is not without its challenges, as you all well know, with early on, less than 60% of encounters that had no barriers to initiate or barriers during the call. Clearly, telehealth can be a challenge. Pritchett, an ASCO young investigator, an ASCO Merit Award winner, is giving us compelling feasibility data that remote patient monitoring probably reduces hospitalization, and I've heard unpublished reports in Europe suggesting similar findings. I do not need to remind this audience about the mental and physical challenges the pandemic continues to have for the medical staff. There have been early estimates of nearly 20% of medical staff potentially leaving medical practice, and I've heard some ICUs already denoting 30% or beyond. I want to especially highlight and want to maybe go back and digest this paper by Dr. Durrani, who summarizes elegantly for us the ASCO clinical and postdoctoral trainee responses and concerns throughout the pandemic on their across the professional spectrum, presented on the left here. In red means concerns. Moving to cancer-specific vaccine studies, the VOICE study presented at ESMO is among the largest cancer-specific vaccine studies. It assesses 2 doses of mRNA vaccine prior to Omicron during Delta, as most of these studies are really for Delta vaccine efficacy assessment that I'm presenting among major cancer therapies. They saw a high rate for most patients developing neutralizing antibodies across most major cancer therapies. Of note, however, there's a small minority of patients that do not develop an adequate antibody response, nearly 7% in the immunotherapy cohort, 60% in the chemotherapy cohort, and 11% in the chemoimmunotherapy cohort. Other US and EU-based cancer-specific vaccine response studies have similar findings. Importantly, almost half of the antibody non-responders or suboptimal responders did develop a spike-specific T-cell response, which is very encouraging news. And we're also getting hints from Dr. Shapiro and Dr. Holmes' team, who assessed the temporal changes over 3 mRNA vaccine doses, pre-post third booster in solid tumors in turquoise colors here versus heme malignancies in red color, with the last time point showing encouraging high levels of spike IgG titers, especially in solid tumor patients. 2 doses of mRNA vaccines among anti-CD20 treated lymphoma patients show on the left figure less than 50% with any seroconversion, and on the right only improved seroconversion if the anti-CD20 therapy was completed more than 12 months prior to the vaccine. So clearly these patients are at substantial risk for poor outcomes. Encouragingly, important vaccine T-cell response in these patients is mostly independent of the timing of the last anti-CD20 therapy or seroconversion status. So some additional immune effect is present even in the absence of seroconversion for some patients at least. Dr. Mela and team assessed recently 2 to 3 mRNA vaccine doses in allogeneic stem cell transplant patients. The above picture shows the antibody distribution of the response. In the interest of time, we'll focus on the lower part of the figure, again looking at the seroconversion of spike antibodies with a substantial reduced seroconversion for transplant patients on myelosuppressive chemotherapy and most markedly again for anti-CD20 treated patients. Multiple myeloma patients also have very severe impairments for immune response, both humoral and T-cell. We're focusing here on the humoral antibody response data again in the left figure, showing multiple myeloma patients versus control, showing substantially reduced seroconversion, and especially seen on the right, this is especially present the case in patients on active therapy as well as maintenance therapy. Important VA real-world study with one-to-one match case control study design assesses breakthrough infections in patients with cancer with over 70,000 patients receiving 2 doses of mRNA vaccine in the early vaccination period between December and May of 2021, when mostly the most vulnerable patients were vaccinated. And cancer patients were not formally prioritized at the time. It's good to remember. Among those vulnerable solid tumor patients, overall vaccine efficacy was 66%, 76% for those on endocrine therapy. Cancer treatment more than 6 months past had an efficacy of 85%, but patients on current chemotherapy across solid tumors or heme malignancies had an efficacy of 57%, and most concerningly, hematologic malignancy patients only observed an efficacy of 19%. With 2 doses, with 2-dose vaccinated patients who end up with symptomatic infections across hematologic and solid tumors at the time, roughly still 10% died, but clearly the amount of infection had substantially reduced. So the absolute numbers will be reduced overall, but this is still clearly a risk, and it will be important to see how 3rd and 4th boosters will perform. And what changes are coming with the Omicron variant of concern? An incredible increase in transmissibility, as well as 2 recent South African studies show us that many more patients are asymptomatic, 15 to 30% were unaware of the infection. Clearly also reduced vaccine efficacy, as well as already starting the 4th booster. CDC has cleared the 4th booster for immune deficient patients and likely is coming for us all, but more data are needed for non-immune deficient patients. And Omicron-specific boosters are being developed, and they are expected within the next few months as well, per recent reports. Reduced drug efficacy also seen. Several monoclonal antibodies already are not effective against Omicron any longer, and are recommended to not be used in patients where that is suspected. And major drug shortages do exist for those monoclonal antibodies that are effective and other oral medications. There is a ray of hope. There is suggestion that this is a variant that is less severe based on South African, UK, and Canadian hospitalization data, but it remains unclear. Is this maybe because it's a more vaccinated immune patient population? And what we don't have yet clear data for unvaccinated patients to clearly answer this question. Also, more and more US hospitals report higher rates of hospitalizations for children. They do appear more vulnerable, and probably most likely the unvaccinated children are probably at greatest risk compared to prior pandemic eras. There are also hints that the virus has predilection more to the bronchial versus nasal or lung tissue, and some have suggested throat swabs. What is already clear, cases have massively spiked in US and have already surpassed prior peaks substantially. And as of January 4th, the CDC data, the hospitalization rates are also expected to surpass prior peaks. What does this do to drug therapy for our patients? Here are the 4 major drugs with remaining efficacy to Omicron listed in order of the preference per IDSA, and the pros and cons that they used to weigh this guidance. Again, this is here for your reference to review in more detail at a later time. Here also, there are summary terms of the urgency of drug start from onset of symptoms. See some of the variabilities highlighted here, as well as what drugs require infusions and how to consider drug-drug interactions and certain drugs, as well as pregnancy. For your review, also the NIH infectious disease team tier of prioritization, high priority patients are clearly immune compromised patients, irrespective of vaccination status at this point. They are tier 1. Besides getting your 3rd and 4th boosters, it is really key all immune compromised patients are aware of these important remaining options for pre-exposure prophylaxis as well as post-exposure prophylaxis in adults, in children, and despite Omicron. The NIH also has released a great guidance document recently to put these Omicron changes all together, and these are here for your review at your leisure. Of note, the FDA has a new emergency use authorization since September 27th for convalescent plasma for immune-compromised COVID-19 patients, for both outpatients and inpatients. Here is a brief overview of the story of convalescent plasma. Just want to, in the interest of time, just focus on where we started with large randomized controlled trial data that were really negative, including high quality, high titer study in the New England Journal in vulnerable older patients started within 7 days. Some smaller studies had been positive, but many had imbalances or other methodologic limitations and challenges. And concerning viral mutant evolutions on convalescent plasma had been reported in multiple reports. I only note one here. But recently, very promising cases of super high titer convalescent plasma in post-vaccination patients were observed where high titer had failed. And there are rumors that randomized trial data will be forthcoming that is positive, large scale trial. And therefore the FDA rightfully updated this new EUA for immune compromised patients. We have major unmet needs that you all need to be aware of. I want to highlight number 5 here, in particular, that does not get much discussion and is most crucial for our immune compromised patients. We urgently need an immune correlate to clearly identify those individuals that are still unprotected by a vaccine response. This will be potentially important for us all if particular novel variants keep challenging our vaccine efficacy. And not to forget the other most critical unmet need that will define the length of this pandemic, and that is the global disparities of vaccinations, which increase the chance for novel variants to emerge even further. And yet, as of January 1st, the low-income countries still had only 1% of its population that were vaccinated. They desperately need our help. In this global war against the global virus, none of us are safe until all of us are safe, as the EU president said so poignantly in 2020. What is my prediction about the future of the pandemic? Just briefly, I do believe we will master the concerning aspects of COVID-19, but we really need to meet the unmet challenges of the ever-evolving virus and vaccine needs. Starting on the left, to briefly summarize all the major confirmed risk factors for severe outcomes, especially mortality from COVID-19 in patients with cancer, clearly advanced age with ever-increasing risk for higher decades, performance status, chemotherapy, metastatic disease or advanced disease, especially lung metastases are emerging, reported at ASCO this year, multiple cancer diagnosis, hematologic malignancies, other immunosuppression therapy in addition to cancer therapy, key comorbid conditions, especially COPD, chronic kidney disease, cardiovascular, HIV, and diabetes mellitus, as well as gender, although job exposure may well play a role here as well. In the interest of time, we cannot review all the other additional risk factors suggested at least in one additional study, but let's just focus on the bottom on additional key systemic therapies that put patients at higher risk. Clearly, stem cell transplant and CAR T-cell with reported mortalities of greater than 30%, lymphocyte-directed therapies, as well as DNA methyltransferase inhibitors, decitabine and azacitidine, for example. They all appear to put patients at increased risk, and likely other emerging heme malignancy drugs to be watching out for. And some questions remain also about the neutropenic period for CDK4/6 inhibitors. What are the major cancer types and specific cancer drug therapies to particularly watch out for? As we just discussed, the leukemias, transplant CAR T cells, anti-lymphocyte therapy, and DNA methyltransferase inhibitors. They are particularly high risk for poor outcomes from COVID, as well as likely of poor protection with vaccines. And be aware of further emerging data for frailty, neutropenia, and lung metastases. There are clearly high rates of severe COVID-19 complications and mortality in patients with cancer. Despite Omicron, these likely further improve with third and fourth boosters, and as well as novel therapies and Omicron-specific boosters. Reducing local and global disparities, also through global vaccination, will be key to really and should be a priority for us all. Unless borderline cancer therapy is expected, treat the cancer with the standard of care in a safe environment, as I'm sure most of you have been doing, and maximize supportive care per COVID-19 and supportive care guidelines, and also probably thoughtful and open conversations around the risk of intensive chemotherapy with expected borderline efficacy, especially in vulnerable patients. Retrospective databases limitations can lead to underestimates of risk factors, and other database limitations such as composite variables, that is without distinct separate variables for each drug regimen or each individual comorbidity, which were used for simplicity, for example, in CCC19 volunteer effort, may also reduce estimates. Dr. Bob Wachter, chair of the Department of Medicine at UCSF, summarized the novel challenges with Omicron best. With Omicron, he says, encounters that were safe a month ago will get you infected now. Many encounters of fully boosted individuals infect each other now. Hunker down for the next 1 to 2 months during this Omicron wave. And as I could only briefly touch on the haunting impact of COVID-19 on mortality in our minority patients, I do want to end with this powerful statement by Bridget Hempstead, who I'm honored to call a true friend and who founded our local advocacy group, who herself had a very disturbing early cancer diagnosis and management story, and who also educated us that this is not uncommon still in her community. She therefore implores us all to include Black patient advocates as much as possible. Thank you for joining us here today at OncoAlert. Stay well.
Thank you for joining us this day 5 and a warm invitation to join us tomorrow for our final day of this colloquium, covering gyno-oncology, the IGCS, and SO sessions with an amazing faculty you won't want to miss. Reminding you that this colloquium video is now available at our YouTube channel and will be available on demand from now on. These will also be available next week through our partners at the European School of Oncology and eCancer in their websites. From all of us at OncoAlert, thank you once again for joining us and look forward to seeing y'all tomorrow.